Hello, I'm Margaret Kelman. I'm the allergy specialist nurse for Allergy UK. I'm going to give a little bit about information about Allergy UK and the work that we do. So Allergy UK provides support and advice and information for people living with allergic disease. We are the leading UK-wide patient charity covering all aspects of allergic disease and manifestations, and this includes both IgE and non-meat-mediated allergy. Allergy UK's vision is for everyone affected by allergy to receive the best possible care and support, that no one should die of allergy, and to raise the profile of allergy at all levels and for everyone in the UK to take allergy seriously. The goal for Allergy UK is to empower, educate, research, resource, and influence, and be ambassadors and the voice of the allergy community and influence change to improve quality of life. Why do people need us? We provide information, advice, and support for the allergic community. We raise awareness of the condition and its impact on quality of life, and inform and advocate on behalf of the allergic community. Allergy UK has a helpline, and it's the only charitable support service in the UK that offers supports on all aspects of allergic disease. And to date, we have 4,300 helpline calls and web chats, and over 3,000 emails to our helpline. We have a health advisory board with over 444 specialists, including allergy specialists, immunologists, dietitians, and primary care professionals. We have a lot of social media, and every month our e-news publication reaches over 46,000 people, with 83,300 people visiting our website every month. The website includes our allergy house, weaning resources, and a lots of other kind of fact sheets resources. Allergy alerts, and we have allergy alerts on our website and also sent out to all our consumers, because often foods have to be withdrawn or recalled, and this is a way of kind of ensuring that people can stay safe. We have lots of fact sheets available on our website, and these are produced in-house by our clinical team and then peer-reviewed by allergy specialist clinicians, and they're available for downloading free of charge from our website. We're involved in a lot of surveys and research, and so far we've written a lot of kind of articles for research. We're involved in a lot of kind of patient support information and surveys, which we quite often host on the website, that goes into producing credible research for those living with allergies. Extending our influence, we'll represent a lot of the allergic community in consultations and collaborations with different departments. One of our advisors at the moment, Allergy, our nurse advisor, is involved in a forum with the Food Standards Agency, and we also are involved quite a lot with guidelines with NICE and BSACI, so that we can kind of give the patient perspective on any guidelines that are developed. So link here for useful information, and there's some useful websites here. So welcome to the main event, the Allergy UK Masterclass webinar, entitled Stepping into Spring, a focus on seasonal allergy. The class today will focus on the following topics: allergic rhinitis, eczema, asthma, and food allergy in young people and adults, with a focus on seasonal allergy. Each session is 45 minutes long, inclusive of questions, and these can be posted on Slido, on our webpage, or via the app with the event hashtag Allergy UK 3103. So that's hashtag Allergy UK 3103. A 15-minute break follows session 2 at 2:45 to 3 p.m. and the webinar finishes at 4:35 p.m. CPD points are available for attending each live session, and you'll need to complete the survey provided on a registration email to claim your points. We will email you your CPD certificate. The webinar will be available in the healthcare professional section of the Allergy UK website after the event. Our first speaker today is Professor Jürgen Schwarzer. He is the Chair of Child Life and Health at Edinburgh University and a paediatric allergist within NHS Lothian, and he will talk today on the subject of allergic rhinitis and seasonal allergy.
Good afternoon. My name is Jürgen Schwarzer. I'm a pediatrician at the University of Edinburgh, and I've been asked to speak to you about allergic rhinitis and seasonal allergy. What I'd like to do in the next few minutes is to talk about allergic rhinitis, but since the eyes are very often involved, I will also include rhinoconjunctivitis. I will refer to both seasonal allergic rhinitis, hay fever, and to perennial allergic rhinitis. The signs, what I want to go through then is the symptoms, signs, and the impact of allergic rhinitis, talk about triggers, and then importantly, focus on practical management, pharmacotherapy, and also touch on immunotherapy. And I will finish with some take-home messages. You're probably aware of the typical symptoms of hay fever and allergic rhinitis. They are an itchy nose, a runny nose, bouts of sneezing, a blocked nose, particular in allergic rhinitis that people have around the year, so perennial allergic rhinitis, snoring at night. The eye symptoms include burning eyes, watering eyes, itchy eyes. And an important feature that people often notice is tiredness due to poor sleep. If we talk about the clinical signs, one sort of well-known sign is the so-called allergic salute that you see here, a child that is rubbing his nose upwards. And if you do that repeatedly, you end up with a crease across the back of your nose, a transverse nasal crease. This is a clinical sign that I'm going to show you here that I think is really important, very often overlooked, and I really want to highlight this. So if you look at these three youngsters, what do they have in common? They're all breathing with their mouth open. And that really is a sign that is very often overlooked. So please look out for that. It's due to a blocked nasal passage, and many of these children and young people will be used to their blocked nose and will not notice this as being abnormal or a problem at all. If you inspect the nose, for example, by just using a simple otoscope, you can see what's demonstrated here. So that photograph shows you on the right-hand side the nasal septum, and on the left-hand side you see this round bulge. This is a swollen inferior turbinate with the typical pale mucosa, and this is a sign that's very characteristic of allergic rhinitis. If we're talking about ocular signs, so eye signs in allergic rhinitis, a common finding is a dark discoloration around the eyes, referred to as allergic shyness. And as you can see in this picture, in this area, there are sort of very coarse lines in the skin, which are called Denny Morgan lines. So this is basically a form of localized eczema on the eyelids in people with allergic rhinitis and associated conjunctivitis. Then you can obviously get an acute conjunctivitis of the eye. Here you see an eye with an injection of red vessels. And sometimes people develop what's called chemosis. And I don't know whether that shows well, but it's basically a swelling of the conjunctiva, which can be really visible and bulge forward. Sometimes it impairs vision. So just to repeat, the typical signs and symptoms of allergic rhinitis and allergic rhinoconjunctivitis are rhinorrhea, bouts of sneezing, mouth breathing. Sometimes you may see people doing this allergic salute, or they may have a transverse nasal crease. On inspection, a typical sign are the enlarged inferior turbinates with a pale mucosa. And then you'll see that people often have conjunctivitis, particularly in hay fever. They may have allergic shyness and these Denny Morgan lines. And I will not refer to that in more detail, but they may have signs of asthma. Asthma is a really important comorbidity of allergic rhinitis. So let's think about the impact of allergic rhinitis on people. So first of all, I think it's important to appreciate it's a very common condition. It's thought to affect about a quarter of the population, of the adult population in the UK, and maybe something like 10 to 15% in children. And the prevalence of allergic rhinitis has been increasing over the last decades. Studies have shown that the symptoms that we just discussed are sufficiently significant that people really end up with a reduced quality of life, and it is lower than the reduction, than the quality of life that is found in people who live with asthma. I think a very important aspect is that the majority of people with allergic rhinitis have poor sleep. The allergic rhinitis interferes with their sleep. I think the mechanisms are probably similar to obstructive sleep apnea, where the deep phases of REM sleep that we all need to be well and function well don't occur. So these people are tired, they have difficulties concentrating, they may be irritable. Depression has been described in this context. And really importantly, if people are tired, they will perform less well at school or work, or they will, because of their symptoms, not even be able to attend school and work. So this leads to considerable direct costs for treating allergic rhinitis, but a lot of indirect costs through lost productivity as well. So just to come back to the question and to illustrate the effect on productivity, this is a study that's been conducted a few years ago, where people with either mild allergic rhinitis or moderate to severe allergic rhinitis were asked to which extent they felt that their productivity was reduced, and how often they were unable to go to work because of their allergic rhinitis. And you see the patients with the mild allergic rhinitis in the blue bars, and those with the more severe allergic rhinitis in the brown bars. And in the middle, there's a bar that indicates the 50% border. And this study really highlights the people who feel that their productivity or that the days at work are reduced for 50% or more. And if you look at people with a mild allergic rhinitis, it's about 25% of that population who report that their productivity is impaired by more than 50%. And if you look at people with moderate to severe allergic rhinitis, it is about half, 47% of people who felt that their ability to work and be productive was reduced by more than half. So this seems to be a major effect on productivity. So let's talk about diagnosis of allergic rhinitis and allergic rhinoconjunctivitis. So we've already gone through the signs and symptoms, and it's really if people have 2 or more of the typical symptoms for more than an hour a day, and these are again a watery rhinorrhea, sneezing, especially if people have bouts of sneezing, nasal obstruction, nasal itchiness, and a conjunctivitis. If that's the case, an allergic rhinoconjunctivitis or rhinitis is likely. What I'd like to do now is focus on signs and symptoms that make an allergic rhinitis unlikely, and this is really quite important. Unilateral symptoms, so symptoms just on one side of the nose always, are unlikely to be due to an allergic rhinitis. If people just have nasal obstruction and no other symptoms, again, that doesn't fit. If people have mucopurulent discharge from the nose, so pus coming from the nose, either anteriorly, or if they just have a discharge to the back of their throat with pus and no anterior symptoms, that's not likely to be allergic rhinitis. And pain, recurrent nasal bleeds, and loss of smell are also not features of allergic rhinitis usually. So in these cases, it's important to think about the differential diagnoses. And they include a non-allergic rhinitis, they include a chronic rhinosinusitis, nasal polyps may block the nose and lead to a loss of smell, typically in cystic fibrosis patients, and there are also nasal tumors. So in these cases, a referral to an ENT surgeon is required. What are the triggers of allergic rhinitis? So I've listed on the left-hand side the typical triggers for hay fever, and they include grass pollen, tree pollen, a number of weeds, and also molds, outdoor molds, particularly in the autumn months. The triggers for an allergic rhinitis that continues throughout the year, a perennial allergic rhinitis, tend to be indoor allergens. And I guess the really most important allergen as far as frequency or how many people it affects is house dust mite. Other important allergies are definitely pets, cats, dogs, if people do horse riding their horse, and other pets. I mean, I've seen people who had an allergic rhinitis driven by rats, which they had as pets at home. And indoor molds also play a role. And then I think that's also important to appreciate. There are also irritants that can trigger an existing allergic rhinitis or can trigger the symptoms of an existing allergic rhinitis. These are not allergens, these are irritants, and they include things like grape flower, lilies, perfumes, diesel particles in the air, fly ash. So things to do with indoor fires, indoor stoves, for example. So regarding hay fever, I think it is important and interesting to have some idea of when the different pollens typically occur in the UK. And this pollen calendar published by Asthma UK is very useful. So the earliest pollens start already in winter, in January and February, and they include hazel, yew, and alder. Then the next big and important group are the spring tree pollens, particularly birch, that usually occurs in March and lasts all the way into June, but also ash at a similar time. And then the big one, certainly here up north in Scotland, where I live and practice, is grass pollen. They tend to occur from the end of April and then over the summer months, and may last all the way into September. These maps illustrate the average pollen levels across the UK. And you can see that there are big differences. The southeast and up into the Midlands has the highest pollen levels on average. If you go further north, this drops down a bit, but even here in the central belt of Scotland, we do get relevant levels of tree and grass pollens. When I put the slides together, I was not able to get an up-to-date pollen forecast from the Met Office. So I'm showing you here an old one from June last year. And you see that this really reflects what the average map shows you. Very high levels of pollens in England, here also into the north of England, and also Northern Ireland. Slightly lower levels in Scotland. At that time, it was grass pollen. I did check the Met Office website today, and they show high pollen levels for southern England, and then lower levels further north. At this time of the year, this is not grass pollen, but this is primarily birch pollen and other tree pollens. So let's think about the management of allergic rhinitis and allergic rhinoconjunctivitis. I think there are three major approaches. The first approach is to try and reduce or avoid exposure to the allergens and irritants. The second approach is pharmacotherapy, so medical therapy. And the last approach that I think one should think about more than we usually do is the possibility of immunotherapy. So let's start with perennial allergic rhinitis. The main trigger for many patients is house dust mite. And it's possible to reduce the exposure to house dust mite. We're all exposed to house dust mite primarily in our beds. So therefore, using house dust mite proof covers to encase mattress, pillow, and duvet is a measure that can be really helpful for many patients. It's also possible to wash pillow and duvets at 60 degrees Celsius regularly, and that will also reduce the house dust mite burden. Being a pediatrician, we also need to think of toys, furry toys, which will harbor lots of house dust mite. So reducing their number if possible, again, washing them at 60 degrees, or if this is not possible, freezing them will help reduce the house dust mite burden. Regarding pets, I think it is very important to at least to avoid that the pets are in the vicinity of the person who has an allergic rhinitis that is driven by their allergens. And I think in many cases it will be necessary to remove the pets from the household. And I think that is particularly important in people who have an allergic rhinitis and concomitant asthma symptoms. You can also, or you should also avoid irritants if they are a trigger for people, and that might be avoiding fresh flowers in the house, avoiding perfumes, and avoiding open fires. For hay fever, there are ways to try and reduce the exposure to pollen. Pollens tend to be highest on warm, windy days, late in the afternoon or in the early evening, and pollen forecasts may really help in judging whether pollen levels on a particular day are going to be high. On such days and at these times, people with significant hay fever should consider staying indoors, reducing outdoor activities, keeping windows shut. And if they had to be outdoors, it is really advisable that afterwards they change their clothes and wash their hair, because these clothes and hair will keep showering them with pollens if they've been outside. Now, for both perennial allergic rhinitis and seasonal allergic rhinitis, nasal douching may be really helpful. If you've been exposed to allergens and they sit on the mucous membranes of your nose, they keep having their effect as an allergen. They keep triggering the allergic immune response. So washing them out is really effective. And there are different devices that enable people to rinse their noses with saline solution. And I certainly have several pediatric patients, young people, teenagers, who started doing this and for whom this has been extremely helpful, much more helpful than the medical therapy that we're going to talk about next. So, thinking about medical therapy, many people with allergic rhinitis will self-medicate and buy over-the-counter antihistamines. These should be non-sedating antihistamines rather than chlorphenamine, which many people take, which is sedating. And it may also be useful to use topical antihistamines. But if that's not sufficient, the mainstay of treatment and the treatment with the best evidence base are intranasal corticosteroid sprays. They can be combined with an oral antihistamine. If you prescribe an intranasal corticosteroid, it is vital that you teach the patients how to use them properly. And I should have included a slide to that effect, but unfortunately I did not. So I'll try and take a minute or two to talk you through that. You want the nasal steroid to go to the lateral aspect of each nostril and to go deep into the nostril. So therefore, the recommendation would be for people to bend their head forward when they use a nasal spray, to take the nasal spray into the right hand, to use it on the left nostril, and then after that, to take it into the left hand to use it on the right nostril. That will guarantee that the nasal spray goes laterally rather than just spraying at the nasal septum. And the most important advice is that while people spray, they should just take a slow, normal breath. They must not sniff, because if they sniff, the medication goes to the back of their throat, is swallowed, and most of it is not available in the nose, and it becomes much less effective. If treatment, or the other thing to say about nasal corticosteroids, you need to let patients know that they're not a miracle medicine that works overnight. It may well take a week, 2 to 3 weeks in somebody with an established allergic rhinitis before the people really feel a good effect of the nasal steroid and really see a significant reduction in symptoms. So you need to tell people to actually stick it out for that time. A further step may be using a nasal spray that combines a steroid together with a topical antihistamine. And then there are a few more interventions that you may want to try in adults who primarily have massive watery rhinorrhea. Ipratropium, bromide spray may be helpful. You can try leukotriene receptor antagonists. You can briefly try decongestant to enable, for example, the intranasal steroid spray to enter the nose. And for important life events like exams, weddings, you may want to give oral steroids at a low dose for a few days. So before I finish up, I want to talk about immunotherapy. I briefly want to try and explain the concept behind immunotherapy. So the aim of immunotherapy is to induce an immune response that will downregulate the allergic response. So what you do is you apply an allergen to a place in the body where the immune system and the cells that present allergens to the immune system are inactive. And this would be either underneath the skin with a subcutaneous injection or underneath the tongue. And if you do that, the allergen is presented to the adaptive part of the immune system, to T cells. And the main thing that happens then is that induced regulatory T cells are generated. And they release mediators, including interleukin-10, which is a mediator that's a strong regulator of immune responses. In addition, these regulatory T cells inform the antibody-producing B cells to start producing allergen-specific antibodies, but not IgE antibodies, as you see in allergy, but IgG4 antibodies. So in the acute immune response, these IgG4 antibodies become important. They are in the circulation and they will settle on all kinds of cells, but in particular also on mast cells and basophils. And if the allergen is provided, they will engage with the allergen and capture it and prevent engagement of the allergen with the IgE antibodies and thus prevent activation of the mast cells and basophils. And you will not get the histamine release and the allergic response that usually follows. In the sort of delayed allergic response, the regulatory T cells that have been induced are thought to be really important. So they'll come into a tissue like this, where you have the epithelium, you have eosinophils, you have mucus production, you have all kinds of cytokines being made that activate the system. So when the regulatory T cells come in, they will actually inform the activated antigen-presenting cells to switch to an inactivated state. And they in turn will tell other cells of the learned memory, of the learned immunity, to become inactive. And that will result in a downregulation of inflammation, mucus production will go away, and the epithelium will also quieten down. So how does this practically work? So there are two currently used forms of immunotherapy. On one hand, subcutaneous immunotherapy, SCIT, and on the other hand, sublingual immunotherapy, SLIT. Both of these have been shown in studies to be very successful in many people with allergic rhinitis. However, they work best if you have people with an allergic rhinitis driven by a single antigen or allergen, or primarily driven by a single allergen. So somebody who is clearly grass pollen sensitized, has significant problems, but doesn't have any other major respiratory sensitizations, is probably a good candidate. Somebody who's highly sensitized to house dust mite, cat, grass pollen, tree pollen, may not benefit, even if the immunotherapy is successful to, for example, grass pollen, because the allergens, the other allergens remain there and will continue causing problems. There are two contraindications. Well, there's one real contraindication. People must not have poorly controlled asthma at the time of immunotherapy. And perennial asthma throughout the year is viewed as a relative contraindication by many. But if the patients are very stable, very well controlled, it may be possible to provide immunotherapy. Why are these people, or why do we have these contraindications? Immunotherapy has the risk of inducing allergic responses, and in particular, asthma attacks. And unfortunately, in the 1970s, there were patients treated in this way who had asthma, who had a major asthma attack and died. And that was primarily because they weren't supervised. They weren't in an environment where they could be treated properly. So one of the important points is, if you provide immunotherapy, you must supervise your patients afterwards for about an hour to exclude severe side effects or to treat the side effects. The immunotherapy needs to be started out of the pollen season. You do not want to start that when somebody has an active allergic rhinitis. And the main immunotherapy available in the UK is immunotherapy for grass pollen and for tree pollens. If you do subcutaneous immunotherapy, there are different protocols. We use a protocol that provides 6 injections over 9 weeks over the autumn and winter, and this has to be repeated 3 times, so it's given over 3 years. Sublingual immunotherapy is licensed for grass pollen in the UK, and that's a daily treatment over 3 years. So my take-home messages. I think it's really important to appreciate that allergic rhinitis and allergic rhinoconjunctivitis have significant negative impacts on many children and adults. So I think the take-home messages need to be: don't overlook the signs of allergic rhinitis. For example, the mouth breathing. Diagnose it and provide management advice, and if required, medical treatment for people with allergic rhinitis. And if the responses of your treatment and the management advice are clearly insufficient, despite optimized medical treatment, I think it's important to consider allergen immunotherapy, which I guess in most instances would mean a referral to an allergist or pediatric allergist. And I think the other main take-home message is: don't treat people with allergic as having allergic rhinitis who don't have an allergic rhinitis. So consider the differential diagnosis and refer to an ENT specialist if people have unilateral symptoms only, if they suffer from loss of smell, or if the symptoms are primarily pain, discharge of pus, or bleeding from the nose. Thank you very much for listening, and I'll be happy to answer any questions. Margaret, I can't hear you. You're muted.
Sorry, thank you. So thank you very much, Professor Schwartz. A very interesting talk. We do have some questions for you. So the first one we have is: can infants under 1 year old have allergic rhinitis?
I would say it's unusual. I wouldn't exclude it. So I've seen infants with a cow's milk allergy who clearly had nasal symptoms, potentially driven by exposure to cow's milk protein, but they were symptoms of allergic rhinitis. I would not treat that as allergic rhinitis, but would treat that as a cow's milk allergy primarily. I think it's possible that really small children do have responses, for example, to pollen in the nose, but it's certainly nothing I frequently see.
Do you more often see responses to pollen in the skin rather than the nose to begin with?
That's it's difficult to say for me, because people usually present because of their nasal symptoms. And when people present to pediatric clinics or to my clinics with significant eczema, that is usually not pollen induced. Saying that, I think it's very important to think about house dust mite as a trigger for eczema, also in infants, because that sometimes is a major driver of their eczema.
Thank you. So the next question is, can you recommend a device for nasal douching in a 3.5-year-old? And would you recommend nasal douching in a child so young? Or would saline drops or spray be more efficient?
I've not had kids that age using nasal douching. And I would love to refer that question to an ENT colleague if there's anyone in this seminar later on. I don't feel that I would have my doubts whether you would manage to do nasal douching on a 3-year-old. I would probably try it with a nasal spray if it's felt required. Again, a 3-year-old, it's uncommon for them to have significant allergic rhinitis.
Thank you. I'm struggling to see the last question. What types of pollen would you suggest should be tested for with skin prick testing?
So before answering that directly, I think the most important thing is to take a history and to try and find out when children have symptoms, or adults for that matter, have symptoms of allergic rhinitis, because that'll give you some indication as to which the likely offending pollens are. You can test for grass pollen. You can test for example, for different tree pollens, for birch pollen. But these tests will not really make any difference or have any consequence unless you intend to do immunotherapy. Because before that, the recommendation to try and avoid exposure and also the recommendations on medical treatment of allergic rhinitis are not dependent on knowledge of which pollen you're dealing with. What you do need to know is when the symptoms arise, typically, and to start if you do need to provide medical treatment, to start that ideally before the symptoms set in. So what I usually do is I ask people to start if they have an inhaled a nasal corticosteroid, to start that about 2 weeks before symptoms typically appear, and then to continue that treatment throughout the pollen season if they are people who have previously had significant hay fever symptoms.
So we've got a few questions here about treatment options. So basically, for patients with allergic rhinitis all year round, can they use the nasal spray long term? And that would be both, need to answer that both for pediatrics and then for kind of older.
So the answer is yes. So if people have a significant perennial allergic rhinitis, some people require ongoing treatment throughout the year. What I would try and do is there's no fixed rule, but I would try every 4 to 6 months to see what happens if the nasal spray is stopped. But if they quickly develop symptoms again, I would provide the corticosteroid nasal spray again. What you don't want to do is treat people for many years without ever testing if they still need the treatment.
The last question is there much difference between nasal spray and oral antihistamines, or are they similar in efficacy?
I'm not aware on studies of studies on that. Theoretically, they should have very similar efficacy. I think the difference is that if you use a nasal antihistamine, you have higher concentrations of the antihistamine locally, topically, and I think that may lead to stronger beneficial effects and potentially quicker effects as well.
And we've got one more question here. Do you ever consider using Kenalog?
You need to tell me what Kenalog is. That's nothing I'm familiar with. Is that a trade name for an?
It's steroid injections. It's steroid injections, corticosteroid injections.
So that's why I'm not really familiar with it. As a pediatrician, I definitely would not. I think long-term systemic steroids is not an option in allergic rhinitis. Short-term treatment, yes. As I said earlier, if you have important life events, exams, other things where people need to be able to function, then that's justified, but I would not put anybody on a longer term systemic steroid for allergic rhinitis.
We can still keep going with some more questions. Okay. Is it beneficial to start inhaled steroids early? So before the spring season begins or before the summer season begins?
Yeah, I think I referred to that earlier. So not inhaled, intranasal steroids. I would start them. People usually know when their symptoms tend to start, and I would start them about a couple of weeks earlier. If you provide that as a sort of local anti-allergic treatment, you prevent the onset of the allergic inflammation in the nose, and then things become much more manageable. If you have somebody who has developed sort of their full allergic inflammation in the nose and have the full symptoms, it is much more difficult to try and bring these symptoms back down by treating with corticosteroids.
And do you ever give double immunotherapy to grasses and trees simultaneously?
I've not done that. I think some people do, and I think it is something that is theoretically possible to do. I don't think one immunotherapy is going to inhibit the other. I would still do this with separate injections, but we don't have mixed products. In Europe, in the United States, people would mix different allergens into the same injection and provide immunotherapy with that. But in Europe, that is something we don't tend to do.
Thank you.
Maybe if I can just add to that, if people have different sensitizations, I would try and, from the history, try and find out which is likely to be the trigger that causes most problems. And it's very rare that people have, at least in kids, in my experience, that people have really significant symptoms that can't be controlled with medication, both to tree pollens and to grass pollens. Usually one of them is manageable and the other one is not manageable. And in that case, I would treat with immunotherapy the allergy that does not seem to be manageable.
Thank you very much, Professor Swartz, for your time.
Okay, thank you.
Hello, I'd like to now introduce you to Dr. Paula Beattie. She's a consultant dermatologist at NHS Greater Glasgow and Clyde, and will be talking to us on eczema and seasonal allergies. Over to you.
Hello, good afternoon. Now, apologies, my clicker is not working, so I'm afraid if you can just move the slides for me. So I have been asked to talk to you today about eczema and seasonal allergy. But I'm going to focus on why the association with eczema and seasonal allergy, and also seasonality of eczema or flares. We now know that about a quarter of children under 5 have eczema. If you could go back to the last slide. Sorry, this isn't going to work. Apologies. And about 15% of school children, about 10% of adults. It is more likely if a parent has eczema, hay fever, or asthma. And there's been a dramatic increase in prevalence in the last 30 years. And that suggests that the environment is critical in determining the development of eczema, because the genetic makeup of the background population changes only very, very slowly over hundreds or thousands of years. Next slide. There's an increasing understanding that we are born with a genetic tendency to get eczema. We know that if your parents have eczema, you're more likely to get it. And we notice drying of the skin measured by water loss from the epidermis by day 2 of life. It then appears that if you go home and start using baby washes and baby shampoos and other detergents that remove oil from the skin, that you increase the barrier disruption that you've inherited, and that leads to more water loss, more drying of the skin, and that allows penetration of irritants and allergens through this leaky skin barrier. There also appears to be some method by which you then develop allergy and an immune imbalance. Next slide. So in terms of the genetic tendency to get eczema, a filaggrin mutation is the best candidate gene. Now that is a structural protein within our skin that helps to form the skeleton of the skin. And when that is mutated, the skin is dilapidated, so it doesn't look like it should. It's not nice and tight and close together. The filaggrin also then breaks down to form a natural moisturizing factor, so that mutations in that filaggrin gene lead to a poorly formed stratum corneum that is prone to water loss, but that is also very dry and missing natural moisturizers. Now, the filaggrin mutations are carried by about 10% of the background population. Those with keratosis pilaris and very hyperlinear palms, so a very lined palm, you're much more likely. That sort of signifies a filaggrin mutation. And 50% of those with eczema have a filaggrin mutation. So it isn't the story in everyone, but it is in around half of people with eczema. And it may be that other structural proteins are involved in other people that we just haven't discovered yet. Next slide. We now know that filaggrin mutations are associated with eczema that is early in its onset and persists into adulthood, and that it is moderately severe rather than mild. Next slide. Next slide. We also know, sorry if you could go back. And next slide. We also know that filaggrin mutations are associated with eczema that is seen in association with asthma. So you're more likely to have asthma if you have a filaggrin mutation. So somehow that leaky skin barrier is also associated with other atopic disease. Next slide. And that really confirms what we've known clinically for many, many years, that if you have eczema, you are more likely to go on and develop allergic rhinitis or asthma. And also that actually, if you have asthma or allergic rhinitis as an adult, you were more likely to have had eczema as a child. And the atopic march is a term that is used to describe the temporal association between eczema and other allergic diseases or atopic diseases. And we know that eczema is the first thing to form with that day 2 drying of the skin, and then quickly developing food allergies, which then resolve, and later developing asthma and hay fever. So it appears that eczema is the causal entry point for these other allergic diseases. Next slide. So there's now a greater understanding and recognition of what the pathogenesis, and we can look at models for that. And it seems that that abnormal skin barrier allows the penetration of food allergens and aeroallergens, and that the body then becomes sensitized to those when it is exposed to those first through this abnormal skin, rather than through the nasal mucosa, the respiratory mucosa, or the gut mucosa, and that the early development of eczema. So it may also be that if you restore that skin barrier with effective management of eczema, that you may reduce the subsequent development of asthma and rhinitis. Next slide. So seasonal aeroallergy. If you could click 3 times. So aeroallergens are a term for allergens that are in our environment, including the likes of house dust mite, pet dander, and pollens. And these are known to trigger allergic rhinitis, allergic conjunctivitis, asthma, and urticaria. But actually, the triggering of these, of eczema, although eczema is associated with these, the triggering of eczema by aeroallergens is not actually well proven. Next slide. So if you click 2nd time. So in terms of grass, there are a few small, low-quality studies that have failed to demonstrate an association between grass exposure and eczema severity. In terms of tree pollen, there is really no evidence of an association. Next slide. So what about house dust mite? And that's also in the air and termed as an aeroallergy. Well, 1/3 of eczema sufferers do report worsening of eczema after dust exposure. House dust mite is known to have proteolytic activity that may degrade the skin barrier. Now, house dust mite likes a humid atmosphere, so it will proliferate in a humid atmosphere. Now, while that is not seasonal per se, we, and particularly in the UK, have a tendency to not open our windows in the wintertime and to dry clothes indoors in the wintertime. So we tend to have a much more humid environment indoors over the winter months, which is often when individuals with eczema notice their eczema getting much worse. But in terms of then removing that from the environment and improving the eczema, well, there is actually very little evidence that removing house dust mite from our environment, which is incredibly difficult to reduce and it's impossible to remove, so there's very little evidence that that reduces eczema severity. Next slide. So do we investigate for seasonal aeroallergy? Well, not for eczema alone. But I do investigate for this if there's allergic conjunctivitis or rhinitis that is very significant. Because actually, if you look for sensitization to aeroallergens in children with eczema, the vast majority of them are sensitized. And it doesn't really tell you whether it's causing an issue or not. Investigation can include total and specific IgE, which can be done in practice, or skin prick testing, because this is an acute type 1 allergy. Next slide. So, grass pollen and the skin. Well, grass pollen certainly does trigger urticaria. Urticaria from grass is reasonably uncommon, and you will generally only see that if you also see allergic conjunctivitis and allergic rhinitis. When you do get it, it tends to be periorbital because an individual has developed irritation of the eyes, they've rubbed the area, and then they have managed to penetrate aeroallergen that's sitting on the skin into the skin. So it tends to be sites of direct contact, so those exposed sites. You will tend to get it in children if they're playing football and they've slid on the grass or they've rolled on the grass, so areas that have been in contact with the grass. But when you get urticaria in relation to grass pollen, it settles within 24 hours with no long-term skin change. So it goes back to normal skin within 24 hours. So do I then do I then ever ask about aeroallergy? Well, I do. I do if the individual is presenting with marked periorbital eczema. Now, the area around the eyes is very susceptible to developing eczema. It is a naturally dry area with no oil-secreting glands. It has thinner skin, and therefore it is also susceptible to penetration of irritants. So individuals with very dry skin and eczema on their face will often tell you that a cream in particular that contains lots of preservatives stings around the eyes, but the rest of the skin is okay. And that's because the preservatives or perfumes and irritants in the cream penetrate that thin skin much more easily. People do tend to rub, back to the last slide, people do tend to rub their eyes when they are tired or dry, the eyes are dry and itchy. And we know that individuals with atopic eczema have reduced, even if you can't actually see allergic conjunctivitis, they also tend to have reduced tear film quality and abnormality of the surface of the eye, so that the eye does tend to be very dry. And when the conjunctiva are inflamed after exposure to an aeroallergen, they become much more itchy, and then individuals rub the area. So association with periorbital eczema and aeroallergy is very common. Next slide. Thank you. So what is the mechanism of periorbital eczema flares when you have aeroallergy? Well, it is that itch related to allergic conjunctivitis, and then mechanical trauma to the skin induced by rubbing and scratching the area when it's itchy. And it is that mechanical trauma to the skin that sets up the inflammation and triggers the eczema locally in this area. Next slide. So how do you tell whether it is aeroallergy or it's contact allergy? By looking in the eyes. If there is evidence of injection of the conjunctiva, if you pull down the lower lid and you can see injection of the inner lid, or even papilla on the lower lid, then this is likely to be allergic rhinitis. You will often see thickening of the lids from just constant rubbing, and they can sometimes have sparse eyelashes because they are rubbing out their eyelashes. If the eyes are completely unaffected, consider irritant dermatitis, or contact allergy. So how to look for contact allergy? Well, exclude the conjunctivitis to start with. Look for other sites where you would notice contact allergy, like the fingertips, where you have been touching the allergen and then rubbing your eyes, or the palms or soles, and take a history. Now, in terms of around the eyes, fragrance and creams, metals, you can transfer from your hands, but you can also, people who use eyelash curlers that contain nickel. PPD is black eyelash dye, but you can also transfer that from your hands. Rubber compounds from goggles in Keen's swimmers, preservatives in creams, cosmetics and cleansers, adhesives. People use false eyelashes and use an adhesive to stick those on. People sometimes perm their eyelashes. And when it becomes complicated is the likes of eye drops. So individuals who have allergic conjunctivitis often use eye drops, and those too contain preservatives. So you can develop an allergic conjunctivitis that is secondary to allergic aeroconjunctivitis. Contact lens solution is another thing to ask about. And the investigation for this, because it's a delayed type 4 sort of eczema-like reaction, is patch testing. Next slide. The other place that I will often ask about aero allergies is when I see eczema that's particularly bad under the nose and upper lip. And that's often associated with allergic rhinitis. And you get an itchy nose or a nose that's constantly dripping. And an individual is either constantly rubbing their nose or rubbing underneath their nose because the area is itchy. And that area can become very thickened and lichenified. So I will generally always ask about that. Now, this was a very interesting paper that looked at environmental triggers and risk factors for in the management of atopic eczema. And you can see that aeroallergy is not actually mentioned, but there are lots of other things in the environment that contribute, and these can be seasonal, like temperature, humidity, UV radiation or sunlight, precipitation or rainfall, although you could argue we get rain all year round, and air pollution, including smoke, and that's more likely indoors in smokers in the winter who haven't opened windows. So eczema and its triggers can be very seasonal, but seasonality does not always equate to seasonal allergy. Next slide. So looking at seasonal flares in eczema, and anyone who looks after individuals with eczema will know that in the majority it is very seasonal, but that those seasonal flares are not actually triggered by seasonal allergy. They are, however, very associated with our environment, which is seasonal. Those things can be house dust mite, which I said is more likely in the winter because of humidity indoors, heat, and UV radiation. And those individuals who tell you that they flare much more in the summer, it tends to be very flexural. And that is often due to heat and sweating, and our flexures are more susceptible to that. And winter flares tend to be very much humidity and often the exposed sites. So round the face, the arms, and the neck area, which are exposed to very dry air. Now, exposed site eczema, and I've just told you that seasonal allergy and exposed sites aren't related to flares of generalized eczema. And here you see a boy with a marked cutoff around his neck on all the exposed sites. And actually, this is photoaggravation of eczema. And you can get photoaggravation of eczema, and you can also get chronic actinic dermatitis. And these are really just aggravation of eczema and also an allergy to sunlight in chronic actinic dermatitis. And when it is the sunlight that is causing the issue, rather than the likes of house dust mite what you find is that you get sparing behind the ears, sparing under the chin, in the sites that don't get the sunlight. So it is actually, if you look for these clues, you can tell whether it's actually the UV radiation or it is actually other things in the environment. Next slide. So chronic actinic dermatitis is what I mentioned as an allergy to sunlight. It's reasonably uncommon, and it's usually actually in older individuals, although I've shown you it in a child. It tends to be much worse in the summer, although it can be year-round, and it is a sensitivity to UV light. It is also associated with multiple contact allergies, in particularly to the Asteraceae family of plants, and that is found about 10% of flowering plants are this family. That's often also called the Compositae family. And you'll get that in herbs and weeds and vegetables like lettuce. So I always ask individuals with very exposed site eczema and worse in the summer whether they are keen gardeners. And in addition to, even if they aren't in the garden, it can be related to contact with that plant in a cream, in skincare products. So people commonly come in and tell me that they're not using that paraffin-based things because it's not natural, and they're using natural products. But natural products also have lots of preservatives in them that you can become allergic to, and they have plant allergens in them. So you need to be very careful when individuals are telling you about using plant-based emollients. So how do I manage periorbital eczema? Well, I manage it much in the same way I manage individuals who get urticaria related to grass. And this is the same as allergic conjunctivitis and allergic rhinitis in relationship to grass. Avoiding freshly cut grass, not drying clothes outdoor, antihistamines either before exposure if that's very intermittent, but generally I advise antihistamines from March to October in individuals with really marked periorbital eczema. Applying emollient as a barrier is useful, and that can be applied before exposure and then showering off after you've had contact with the allergen. And I particularly advise that in people who are going to go to the park and they know they're grass allergic, or play football and they know they're grass allergic, they're playing on a football pitch, they know they're going to be in contact. You apply an emollient first. The grass allergen really sticks to the emollient, and if you then wash that off, you've less contact with your skin. If they have allergic rhinitis or conjunctivitis, then manage those appropriately with antihistamine eye drops or nasal corticosteroid. So what about the eczema? Avoidance of soap and cleansers and wipes. Now, all of these, even if an individual is not allergic to these, all of these can also irritate the skin. And soap is an irritant rather than an allergen. But cleansers and wipes are also irritants, as well as having allergenic. And using an emollient as a soap substitute will help with that. Avoiding perfumed products is important because perfume is both an allergen and an irritant. And avoiding makeup in the eye area. Now, makeup contains lots of allergens. It also contains preservatives, which are irritants, and eyeshadow in particular is very, very drying because it is based on talc. Managing the eczema, a thick layer of waxy ointment. Now, as well as providing the barrier to the allergens that I've mentioned, the thick ointments have less preservatives. So ointments don't have preservatives while creams do. So they are less likely to irritate on that very thin skin around the eye. They also provide a lot more moisture in a naturally dry area. And by providing lots of lubrication, because they then sit on the skin, they help to reduce that damage from rubbing of the skin. because you need that as a lubricant, it should be applied liberally and frequently. So I often give them a very small tub as well to carry around with them and keep applying. If the area is inflamed, you need to use an anti-inflammatory, and that should be first line a topical steroid. Hydrocortisone is the safest, and 1% should be used and is safe to use. It should be used for 7 nights for flares, and it can then be used 2 or 3 times each week. And that's safe to continue in the long term. And we know that twice weekly or 3 times weekly use of topical steroids for individuals who repeatedly flare reduces the frequency and the severity of flares. So maintenance therapy should always be initiated. What I do tend to find is that once individuals, if you could go back to the last slide, if individuals are using lots of greasy emollients, that their need for the topical steroid reduces dramatically. If the skin is very, very red and actually almost looks swollen with an acute flare around the eyes, then a moderately potent steroid such as clobetasol butyrate can be used for a few days as a maximum, and then back to the hydrocortisone. However, if 2 or 3 times a week hydrocortisone is not maintaining the eczema and it keeps on flaring, then I will generally switch to tacrolimus ointment. Next slide. Now, tacrolimus is a calcineurin inhibitor, and topically it can be used as a steroid-sparing agent. It suppresses both the inflammatory and the immune response, so it is very, very useful around the eyes where you are more concerned about steroid side effects. Calcineurin inhibitors reduce the severity and the frequency of flares, a bit like using maintenance topical steroid, but without the concern about steroid atrophy in that very thin area of skin. And calcineurin inhibitors and tacrolimus, it's a large molecule and it's actually only absorbed well on areas of thin skin. And these are the areas that actually you're more likely to want to avoid using lots of topical steroid. The 0.03% strength is equivalent in potency to a moderate topical steroid such as Uvivate, and 0.1% is equivalent to a potent topical steroid. Next slide. So how do I use tacrolimus? Well, I use it after the acute flare has settled. The reason for that is it's twofold. Steroids work much faster. They are much better at controlling a flare. So even if you introduce tacrolimus, an individual should still always have a topical steroid at home for acute flares, and they work much faster. In addition to that, when you apply tacrolimus to very inflamed skin during an acute flare, there's a lot of stinging, and that tends to make individuals not want to use it again. So if they switch to the topical steroid for a few days to manage the flare and then go back to the tacrolimus. The tacrolimus is very good at reducing the frequency of flarings. And that, like a topical steroid, can be used once daily rather than twice daily, although the license is for twice daily use for a 6-week period to really bring this under control and clear it. And, you know, unlike with topical steroids, people often use them for a week and then they stop, and the eczema is still there. But we really want to continue using these longer to completely clear, and then using maintenance with this twice weekly. And we've also shown that maintenance with tacrolimus can reduce frequency and severity of flares. The other thing that I do suggest to individuals when they're using tacrolimus to try and aid adherence to using it is to not use it when drinking alcohol, and that is now on the little the package insert. And that's because if you apply tacrolimus after you have drunk alcohol, particularly the likes of red wine, that burning is much more marked. And, if individuals just, have that sensation of burning, they think that it's doing harm and therefore they're not willing to use it. But it's a really useful management for periorbital eczema, but also for atopic eye disease. And that is likely to be due to absorption in around the area, and it tends to improve atopic eye disease. My colleagues in ophthalmology who are trying to manage individuals with really marked keratoconjunctivitis are often very keen for us to start tacrolimus around the eye area and now prescribe it themselves for that periorbital area, and the absorption through the eyelid tends to improve the eyelid disease and in turn the surface eye disease. Next slide. So in summary, atopic eczema is very associated with other atopic diseases, including aero allergies and seasonal grass allergy. Allergies to grass and pollen trigger urticaria in our skin, but not generalized eczema. However, allergic conjunctivitis is often associated with periorbital eczema, and management of that periorbital eczema can markedly improve the allergic conjunctivitis. Next slide.
Thank you very much, Dr. Paula Beattie. Now we've got some questions for you that our audience have posed.
Yep.
So one of them is quite kind of topical for the kind of current climate with COVID. So a few staff appear to have suffered with periorbital eczema during the pandemic. Could this be related to wearing surgical masks?
There isn't generally much in the mask. However, I think that lots of individuals who are wearing the masks with the metal insert over the nose to allow you to shape it around your nose have been getting eczema in and around the nasal bridge from that. Theoretically, you can transfer, but lots of us, what I was talking about with the transfer is that because the eyelids are so thin, you can react on your eyelids to contact allergens without having reaction on the fingertips. And occasionally you will see periorbital eczema with no evidence of eczema on the hands, and it is still due to transfer to those allergens. So theoretically, lots of us are wearing gloves a lot more. And there are lots of things, even if you're wearing a nitrile glove without latex in it, there are lots of accelerators and other chemicals within those nitrile gloves. And if you rub your eyes, which lots of people do, as I said, if you're atopic in particular, if you rub your eyes with the glove on, you can theoretically develop a contact allergy in and around the eye area, simply because you have touched your eyes with something that you're allergic to.
Thank you. So we've got more questions here. So I've got a few people wanting to know more about thinning of the skin around the eyes with the use of hydrocortisone.
So, there is lots and lots of what we call steroid phobia that there is very, very little evidence for. Leaving eczema untreated around the eyes, I should say, and that constant rubbing can cause keratoconus, which actually is a lot more, you can't correct keratoconus once you have developed that. There is very, very little evidence for thinning of the skin out with the area of the face and the flexures from topical steroids. And topical steroids are generally very safe. Hydrocortisone is incredibly safe. It is a very weak topical steroid. And when post-marketing data over many, many years has been looked at for steroid atrophy with topical steroids. It has actually been related to the need to use moderately potent topical steroids, not hydrocortisone, and using over 30 grams of a moderately potent topical steroid over a 6-month period is associated with atrophy on the face and around the eyes. But actually, the use of hydrocortisone around the eyes is actually not been associated with steroid atrophy. And therefore, while lots of individuals come in and no one has wanted to use hydrocortisone, or they've used 0.1% or 0.05, I mean, they're basically almost homeopathic, and they often do not work at all. 0.5% hydrocortisone is sometimes useful around the eyes. It can work, but it generally takes 1% hydrocortisone, and 1% hydrocortisone, if it is only needed 2 or 3 times a week, is perfectly safe.
Thank you. So the other questions are, when should you be looking to have a patient tested? So diagnostic testing, i.e. when would you need to do skin prick testing, or when would you need to do patch testing in a patient with eczema, and why?
So for generalized eczema, we do not do skin prick testing or do IgE tests, because that eczema is a type 4 delayed allergy, these acute ones. So skin prick testing in eczema is only done for food allergens in young infants under the age of a year, or if they've had an acute reaction like any other allergy test. And for aeroallergy, I would not do that in the context of atopic eczema, but if there was marked allergic conjunctivitis or rhinitis, then skin prick testing can be carried out to tell whether, you know, there is grass pollen or tree pollen, pet dander or house dust mite. So it is useful in the context of allergic rhinitis or allergic conjunctivitis, but not for eczema alone. For patch testing for eczema, which is for contact allergens, I would do that for localized areas of eczema, particularly if they have associated it with a cosmetic practice, a change to that, or for the likes of eyelid disease, very markedly hand disease, and individuals if they have occupational exposure. So those are the times that we would do patch testing. But for seasonal flares of atopic eczema and generalized eczema, no, we would not generally carry out patch testing. So only if we think that someone is reacting to something. But periorbital disease is much more likely to be associated with contact allergy. So we are much, much more likely to do patch testing if we see periorbital disease.
Another question, is there a link between eczema and food allergy?
So that wasn't the topic of my talk. There is a link between eczema and food allergy, and I showed you the atopic march, and that individuals who have eczema, really within the first few weeks of life, then develop food allergies. And we know that if you have eczema in the first 3 months of life, eczema that is very facial, eczema that is generalized and very severe, and eczema that does not respond to hydrocortisone on the face and Humavate on the body in a young infant, they are more likely to have food allergies than the background population, and you know, as a driver for their eczema. Beyond the age of 6 months, that becomes much less likely, and beyond the age of a year, we would not generally go and ask about food allergens. So we would generally only ask about food triggers in infants under the age of a year.
Thank you. So in a 2-year-old child with periorbital eczema that's not responding to hydrocortisone, could I start tacrolimus?
Yes. This is when I would start tacrolimus, 0.03% if they have not responded to hydrocortisone, and also I would also ensure that they had used maintenance and that they were using a good thick ointment as a barrier in addition to that, because that can be really, really useful, and also that they are using an ointment rather than a cream, because the ointments are always slightly stronger, but still safe. Ointments don't have that preservative, and it could be that you're putting on a preservative that's irritating all the time, just as the hydrocortisone is benefiting it, that the preservative is irritating. So I would make sure that I had optimized their steroid with a week and then twice weekly, added lots of ointment in, and that they were using loads of that, and then I would switch to tacrolimus.
Thank you. And then another question here. On a 12-year-old with severe eczema around the eyes and face only between January to August, with positive skin prick testing to trees, would you consider immunotherapy or other therapies?
So we know, as I've said, that these aeroallergens do not trigger the eczema. We really do not have evidence of that. But if that individual also, because you would be expecting that if it was an aeroallergen, if they had a positive tree pollen, if they had allergic rhinitis or conjunctivitis, then you would consider the immunotherapy for that. But because these aeroallergens don't trigger the eczema, they would not improve the eczema by having immunotherapy. So there would be no indication to do immunotherapy only for eczema.
Thank you very much.
You're very welcome.
So I think what we can do now is I'm going to play, because we've finished slightly early ahead of time. I think that was actually due to my presentation this morning. So thank you very much to Dr. Paula Beattie for your very, very interesting and informative talk on kind of eczema. We're now going to play the Allergy UK video, which takes about 5 minutes. So this is a short video which has patients talking about their experiences of allergies and the impact that allergies and living with allergies had on themselves and their families. And then we'll go to a short break, and we'll be back for 3 o'clock to reconvene. Thank you.
It's quite hard, especially when you're young, to watch, like being that young going through something like that is quite hard and tough.
You are honestly thinking, is this, is he going to come out the other side of this? Is he going to be alive at the end of this? What's going to happen? So it was quite tough.
The house is quite empty without her. There's no joy really, because she was that basically for us.
When I eat something that I'm allergic to, my body gets swollen up, and sometimes it has a rash as well.
So my son, he's now 6 years old. He has allergies, which he was diagnosed with. He also has asthma. Eczema comes along with the allergies. I think he's got an oversensitive system.
I think most people understand what hay fever is. I don't think they understand the impact it really has on people's lives. Or they've seen the commercials and they think you take a few pills and you should be fine. I think my kids, because I've always had this situation, I think they've grown up with it. I think when they were very young, it was hard to explain, but now they just realize that there are certain days of the year that they might want to do something and it's just not possible.
Our son, Arlo, who is 6, has a range of allergies.
Milk, eggs, sesame, lentils, Loads.
It's a matter of life and death, so we have to make sure Arlo's safe, so we have to ask those questions.
I have had times where I've watched her being so ill. It's so difficult and it's so out of your control.
It was very scary, especially just walking into the medical room because I couldn't breathe. I didn't know if I would make it there or not, and after as well, mentally it impacted me because it was quite a scary experience in my life, so it had a psychological impact as well. I wanted to be around her. It was hard to go to things like sleepovers and stay overnight at different places because I felt like if I was awake something would happen.
My sister Shaida was very intelligent, very funny, had a great personality that was very sassy. Everyone knew that. The main thing is, even for her, she would be raising awareness for allergies by herself as well. I still can't comprehend how people don't realise the severity of allergy reactions. That is also why I'm doing this video, because in Shaida's name, we don't want any more deaths similar to Shaida.
I work as a consultant paediatric allergist at the Evelina London Children's Hospital. I get to meet patients who have incredibly challenging problems, multiple allergies that affect so many parts of their life and all of their families' lives as well. It's incredibly impressive to me and also really inspiring to have the opportunity to work with people who have these problems and to try my best to try and apply science as effectively as possible to help alleviate some of that impact.
Please help us to continue to support people living with allergic disease and their families. Our services are free to the thousands of people who contact our helpline and download information from our website. Help us to help others. Text now to make a donation.
Hello and welcome back to part 2 of our masterclass webinar, Stepping into Allergies. I hope you're enjoying it so far. I'd like to welcome you now to Dr. Dermot Ryan. He is an Honorary Clinical Research Fellow with Edinburgh University, GP and a member of ARIA, that's the Allergic Rhinitis and its Impact on Asthma Initiative. He's going to talk to you today on asthma and seasonal allergies. Over to you.
Thank you, Margaret, and welcome everybody on this fantastically sunny afternoon.
Hello and welcome back to part 2 of our masterclass webinar, Stepping into Allergies. I hope you're enjoying it so far. I'd like to welcome you now to Dr. Dermot Ryan. He is an Honorary Clinical Research Fellow with Edinburgh University, GP and a member of ARIA, that's the Allergic Rhinitis and its Impact on Asthma Initiative. He's going to talk to you today on asthma and seasonal allergies. Over to you.
Hello, everybody. And welcome everybody on this fantastically sunny afternoon.
Hello and welcome back to part 2 of our master Stepping into Allergies. I hope you're enjoying it so far. I'd like to welcome you now to Dr. Dermot Ryan. He is an Honorary Clinical Research Fellow with Edinburgh University, GP and a member of ARIA, that's the Allergic Rhinitis and its Impact on Asthma Initiative. I'll talk to you today on asthma and seasonal allergies. Over to you.
Hello, everybody. And welcome everybody on this fantastically sunny afternoon. Hello, everybody, and welcome to this fantastically sunny afternoon. A real wonderful start of the summer almost, even though it's the middle of spring for all of us. But of course, a bad sign for people, those who suffer from hay fever, who will suddenly start having their symptoms today or in the next couple of days. These are my conflicts of interests. Of particular note is my sponsorship by Viatris, who are the makers of Isolastine fluticasone, about which I'll be talking later on. But this particular talk is not sponsored by them. I was also asked to say a few words about the oral allergy food pollen syndrome, which is really quite common. Most people with oral allergy syndrome have hay fever. But what is oral allergy syndrome? It's a strange sort of little IgE-mediated problem to many fruits and vegetables. When the patient or the person who suffers from it suffers from a little bit of swelling or tingling or itching in their mouth and their lips, which lasts 10 or 15 minutes on exposure to that particular substance. Of great interest is when that substance is cooked, the proteins which cause the problems are denatured and that disappears. So they don't have the problem, for example, with strawberries if it's in strawberry jam or strawberry jelly or strawberry ice cream, because those are processed foods which are in that. It's very difficult to do any actual testing on them because the allergens are very fragile and don't lend themselves to being included in testing solutions. So the only way you could test is prick test, but actually the history tells the whole story. Patients are often quite mystified by it and ask for tests. There's no point. It very, very, very rarely progresses to anything else. The only thing to be aware of is if there's an oral allergy syndrome to nuts, whether that may be part of a greater anaphylactic syndrome. So those patients may benefit from being referred to a specialist for a risk assessment if they have oral allergy syndrome with nuts. The treatment is very simple. It's avoidance, antihistamines as needed prior to taking the foodstuffs. But if they have systemic symptoms outside of the oral cavity, then these patients should be referred to see a specialist. Moving on then just slightly up the face to the nose. What is rhinitis? Well, rhinitis is an inflammation and swelling of the mucous membrane of the nose characterized by a runny nose and stuffiness. There are broadly two types of rhinitis, allergic and non-allergic. An allergic rhinitis is itself subdivided into seasonal allergic rhinitis and perennial allergic rhinitis. And some poor unfortunate people have both. So they're perennial allergic rhinitis with seasonally exacerbated symptoms. Non-allergic rhinitis is caused by other things. The most common one is infectious non-allergic rhinitis, which is due to the common cold by and large. And we all know how miserable we feel when we have the cold, with a stuffed up head, runny nose, feeling tired, not being able to sleep properly. Our sense of taste and smell is sometimes impaired. So have sympathy for the person who suffers from allergic rhinitis, because they have symptoms like that for more than 3 or 4 days. The other types are vasomotor or senile rhinitis, which is just clear runny nasal discharge from the nose. Occupational, which requires referral to an occupational physician. Hormonal, particularly the oral contraceptive pill. Drug-induced, for example, non-steroidal anti-inflammatory drugs. Gustatory, such as wine and chili. And idiopathic, when there is no clear cause for it. So what is seasonal allergic rhinitis? It's an allergic sensitivity to airborne mold, spores, or pollens from trees, grass, and weeds. It's classically called hay fever, but of course it occurs outside of the time of the grass pollen season. And it may occur on its own or with asthma, and this is the important thing. There is no longer just one single hay fever season. There are many different seasons, which can vary in intensity from year to year according to the pollen count, but also according to other atmospheric conditions such as humidity. And it is one of the forms of allergic rhinitis, along with perennial allergic rhinitis. So for completion, what is perennial allergic rhinitis? It's an allergic sensitivity to airborne or house dust mite, cockroach, and animal dander. It may also occur on its own or with asthma, and may have accompanying seasonal allergic rhinitis, and is the other form of allergic rhinitis. Of great note is that pets may carry seasonal aeroallergens in the home during the seasonal hay fever season. So the pollen seasons in the UK and across Europe vary. This is 2 areas of the UK, Scotland and in East Midlands, and we can see the prevalence and the strength of the pollen season varies quite considerably from Scotland to the East Midlands, the area in which I live. So in particular, we get high nettle counts and grass pollen counts, whereas they don't get such high levels of nettle counts in Scotland. So the chart is different for every single area of the UK. So let's go back to the first description of hay fever appearing in the English medical literature, because it did appear in German medical literature before that, from a clinician called John Bostock, who describes about the beginning or middle of June in every year, a sensation of heat and fullness is experienced in the eyes. And to the sneezings are added a further sensation of tightness of the chest and difficulty in breathing. So even 200 years ago, the link between hay fever and asthma was noted. The second document of note was produced by a physician from Manchester called Charles Blackley, and he described very clearly the chest symptoms causing Guitarus aestivus, hay fever, or hay asthma. He describes the chest symptoms. He describes pollen as a causative agent. And he also describes the first dose response curve, noting that the quality and quantity of the pollen spores were relative to the amount of disease and symptoms that it caused. Now, approximately 80% of people with asthma have allergic rhinitis. So this makes it absolutely critical when you're looking at a patient with allergic rhinitis to ask whether they have any chest symptoms, wheezing, chest tightness, chronic cough, night symptoms, exercise symptoms, or if they come with asthmatic symptoms, whether they have any symptoms in their nose in terms of running, itching, sneezing, blocking. Very, very important of a review of either condition that they look at the other area. But also very important to review the diagnosis, particularly in asthma. So I'm just going to tell you about 2 studies. The first one by Sean Aaron and his colleagues, published in British Columbia a couple of years ago, looking at patients who had a recent diagnosis of asthma and going through their notes and finding out how many of them didn't actually have asthma after extensive testing. And about a third didn't have asthma. And of those who didn't have asthma, yes, 28% were asymptomatic, but 25% of those who did not have asthma had rhinitis of one form or another. And in this study from Holland, in an asthma diagnostic clinic, of 644 patients referred with asthma, more than half didn't have asthma, but of those, 99 had rhinitis. So the rhinitis can mimic, to some extent, the symptoms of asthma, particularly from the point of view of the chronic cough that sometimes goes with it. So the takeaway message I'd like to leave you with for this part is that many patients in primary care with a diagnosis of asthma do not have asthma, and of these, 25 to 30% will only have rhinitis. And of those with a confirmed diagnosis of asthma, at least 20% will have allergic rhinitis. So let's just think what happens in allergic rhinitis and asthma. Well, the mast cells, which contain these beautiful pink granules, line most body surfaces, and they're the principal effector cell in allergic reactions. The little pink granules contain granules which contain pro-inflammatory mediators, for example, and particularly histamine, leukotrienes, and prostaglandins. When the mast cell is activated by the appearance of the antigen, which in this case is the pollen, which cross-links the specific IgE molecules lying on the surface of the mast cell, there is a release of these inflammatory mediators, which occurs immediately, and also triggers off the synthesis of new inflammatory mediators, which amplify the response. So in short, the allergen comes along to the allergen-presenting cell. A process occurs by which sensitization occurs. If allergy occurs, the IgE molecules become resident on the surface of the mast cell, and they're bound together by the when they're bound together by the antigen, the mast cells liberate histamine, lipid mediators, enzymes, cytokines, and chemokines, which cause acute symptoms in the upper airways of itching, sneezing, watery discharge, and nasal congestion, and in the lower airways, acute symptoms of wheeze, dyspnea, and tight chest. Then, through the process of recruitment, we see here an activation of other inflammatory pathways through the eosinophils. We see a further release of new things, new mediators, basic proteins, enzymes, lipid mediators, cytokines, and chemokines, which lead to the chronic symptoms of nasal blockage, loss of smell, and what is known as nasal hyperreactivity, about which I'll say a few words in a minute. And in the lower airways, cause airway remodeling and bronchial hyperreactivity with night symptoms and exercise symptoms. So you can see the similarity of events between the upper airways and the lower airways. But of course, histamine has very little effect in the lower airways compared to the upper airways. And there is no smooth muscle in the upper airways, which is why you don't get any wheezing, as it were, in the upper airways. Now, if we look at that in terms of when patients put it with an allergy or put it into an exposure changer, and we can look at what happens when they're exposed to the pollen antigen challenge here, they have an immediate early phase reaction in the upper airways, which is mirrored in the lower airways with a fall in peak flow, or FEV1, which then recovers spontaneously without any treatment. And then, because of the process of recruitment, recurs later, 3 or 4 hours later. Both in terms of symptoms in the upper airways and, of course, with wheezing and shortness of breath in the lower airways. Now, it's very important to recognize that allergic asthma increases the risk of asthma threefold. This study was done on kids going to college and followed up 23 years later. Now, of these children, they were young men, I suppose, when they went to college, only 3.6% of those developed asthma if there was no allergic rhinitis at baseline, whereas if there was allergic rhinitis at the baseline assessment, there was a 3 times more likely possibility of developing asthma. And a similar sort of thing was seen for perennial rhinitis, which is also an independent risk factor for asthma. Having rhinitis predicts poor asthma control, and the worse the degree of rhinitis, the worse the control. So people with mild rhinitis, these are the people who are seen by and large by the pharmacist, are twice as likely to have poorly controlled asthma, whereas those with moderate and severe rhinitis are nearly 5 times more likely to have poor asthma control. And that puts it on a par with cigarette smoking in terms of gaining asthma control. So the takeaway message here is that rhinitis predisposes to the development of asthma, and that concomitant rhinitis leads to less good asthma control. And many patients with asthma have concomitant rhinitis. Coming on to the symptoms then of rhinitis, what are the most troublesome symptoms? Well, both in adults, the dark blue, and children, the light blue, nasal congestion is the biggest problem that people suffer, with a variety, any combination of itchy nose, itchy eyes, runny nose, itchy palate, sneezing, and in children in particular, watery eyes. Now, of course, in the UK, we're troubled by NICE and various other organisations who think they're trying to save money. So this sign has appeared in GP surgeries. Did you know you do not need to see a GP for hay fever symptoms? Many treatments are available without prescription for a small cost. And while this is true, it is condemning those patients with moderate and severe rhinitis to not achieving the treatment that they need. It's also that they are the truth that these patients are more likely to get a first-generation antihistamine over the counter from the pharmacist, and that these first-generation antihistamines are sedating antihistamine. Let me put that into context. This study from Canada, looking at motor accidents over a 3-year period, showed that if you were taking a benzodiazepine over a 3-year period, you were twice as likely to have an accident to somebody who wasn't taking benzodiazepine. If you were taking the legal quantity of alcohol, up to a legal quantity of alcohol, you were slightly more likely to have a motor accident over the next 3-year period. But if you were taking a first-generation antihistamine, you were more than 3 times more likely to have an accident over the 3-year period. This is because of drowsiness and cognition impairment, because of the antihistamine. So hay fever may not kill people, but the treatment we give for hay fever, the old-fashioned, outmoded treatment, may well do that. So another practice audit point, because actually if you look at open prescribing, you'll see that 100,000 people are still taking first-generation antihistamines. So a good audit point would be how many patients in your practice are on first-generation antihistamines. These are mainly chlorphenamine, but also diphenhydramine and brompheniramine. These should be switched to second-generation antihistamines. Let's just look at a place where most rhinitis management is carried out in the pharmacy. This study came from Australia, where 70% of patients with rhinitis self-manage. So of these 300 patients who were interviewed with nasal symptoms, only less than half had a physician diagnosis. 40% nearly had moderate to severe symptoms impacting on their daily life. Note that nearly 80% of both purchased intranasal steroids or oral antihistamines, but that means there's a considerable overlap and that many people were purchasing both oral antihistamines and intranasal steroids. More of that in a minute. But more importantly is patients in a pharmacy were 4 times more likely to experience moderate to severe wheeze. In other words, those patients with asthma related to rhinitis were being ignored. So I put it to you that we need to give the person who has allergic rhinitis or hay fever seeking a consultation the time of day and listen to their story so we can manage them properly. One thing a pharmacist can't do is do a physical examination, which helps to confirm the diagnosis, looking for the allergic crease in the nose and constant rubbing of the nose, the allergic shyness, which our last speaker talked about in the context of eczema, Denny-Morgan lines occurring in those shyness, hypertrophy of the turbinates, nasal polyps. Nasal polyps are always an indication of poor asthma control, but if they occur pre-pubertally, it suggests that this patient has got cystic fibrosis and needs to be referred to see a pediatrician. Deviated nasal septum, which is never going to respond to any medication and will need surgical attention. And of course, in children, foreign bodies are sometimes the culprit. It's very important then to classify allergic rhinitis by severity, and this is the ARIA classification. In people with mild allergic rhinitis, they have normal sleep, normal daily activities, normal work and school with no troublesome symptoms. And the symptoms don't necessarily occur every day and not for long periods of time. In those with persistent, moderate to severe disease, they have symptoms more than 4 days a week and for more than 4 weeks at a time. And one or more of these is impaired. They don't sleep well. Their mood is poor. They have impairment of daily activities, sport and leisure. And they have problems caused at school and at work. In other words, their symptoms are troublesome. And if we look at this study from Jean Bousquet from France, the people who come to visit us in primary care are not those with mild disease, although there are some, of course, but mainly those with moderate to severe disease, and these people require our attention. The ARIA allergic rhinitis care pathways looks as follows. So the patient with rhinitis symptoms may self-care, but that's often not the best thing to happen. If they consult with a pharmacist, they're more likely to get better treatment, and the pharmacist is likely to more recognize when the patient is not properly controlled and ask them to visit their GP for further advice. The pharmacist should also check for whether the patient has asthma or not. Then if they come to see the GP, what does the GP do? The GP checks it all as well, adds in other treatments, and if they don't get control, they refer to a specialist who looks at other potential causes and problems. The emergency care is really those patients who come along with asthma and accompaniment with their acute severe allergic rhinitis, which does occur, particularly in those countries that have thunderstorm asthma. So the takeaway message here is that those seeing a general practitioner are suffering from allergic rhinitis that is having a major impact upon their life, which deserves proper attention, and that a simple physical examination is part of the process of finding out what's going on for the individual patient. The BSACI guidelines were published in 2017, and this is a very slimmed down version of it. Slimmed down because it's much simpler. So in those with mild rhinitis, the patient should try antihistamines or intranasal steroids first, or vice versa, and if that doesn't work, then try the other. If they have moderate to severe rhinitis, then try topical nasal steroids first. If that doesn't work, always check that they're using the medication on a daily basis, because you lose the protective effect of either the antihistamine or the topical nasal steroid if you're not using it on a daily basis. So intermittent use just doesn't work during the hay fever season. When they're using the topical nasal spray, make sure that their technique is good. It's not cocaine. You don't snort it down. And there are pictures available in the BSACI guideline showing how to do that properly. And also a very good video on Asthma UK done by Glenys Gadding showing how it's done. Having checked that the diagnosis is correct, the patient is concordant with treatment, and that the technique is good, and they're still out of control, then add in a topical nasal steroid to the topical antihistamine. If that doesn't work, by and large, refer the patient to see a specialist. Other reasons for persistent symptoms are deviated nasal symptom, chronic rhinosinusitis, nasal polyps, ciliary dyskinesia, and immunoglobulinemia. These things are immunoglobulopathies. These are things which GPs really encounter infrequently and are not really catered to look after. Red flag signs are nasal pain, are sinus pain, which doesn't go away, unilateral symptoms, and heavy bleeding, which suggests that person needs to be referred fairly rapidly. So this is a useful piece of information for generations, myself included. If the antihistamine didn't work, we added a topical nasal steroid, and vice versa. But this is the evidence. So placebo is quite effective. About 15% of people improve significantly on placebo. That increases to about 23% on a second generation antihistamine. A topical nasal steroid on its own will get the success rate to over 30%. Adding the two together adds about an extra 1 to 2%. So by and large, the message here is that adding these treatments together is pretty ineffective. So you're giving two medications, neither of which are terribly effective, and together which aren't any more effective. Sorry, topical nasal steroids are clearly very effective, but adding the antihistamine to it is not an effective therapeutic strategy. Many patients require more than 2 medications to get things under control, and many patients will be using up to 4 or 5 medications to try and gain control. Their life is a nightmare, and again, these people need to be properly referred. Other factors to consider, I mentioned nasal hyperreactivity. This is when other things trigger off the running of the nose, the sneezing and the itching, but it's not necessarily an allergic process. So perfume, deodorant and hairspray are the biggest culprits, followed by cigarette smoke. But cold air and air conditioning do it for a lot of people, as does exercise. Volatile fumes, sulfites in wine and dried fruits may also be a problem, and spicy foods due to the effect, the pharmacological effect of particularly chilies on the nasal membrane and other reasons. So the important thing here to do is to identify what these other triggers are and to attempt to remove them from the patient's life. Now, I mentioned adding in a topical antihistamine to a topical nasal steroid. So this study, a real-life study of patients with confirmed allergic rhinitis, confirmed by skin prick test and or specific IgE, with uncontrolled rhinitis, were given isolastine and fluticasone in combination twice a day. And what we see here that within 24 hours, some people were getting complete control, and a lot of people were getting significant control. But by the end of a 2-week period, 75% of people had complete control, another 15% had a partial control, but there were a number of people who were still left under control, uncontrolled. These are patients almost certainly with severe chronic upper airways disease, and these are the patients that merit referral to see a consultant specialist to improve their treatment. If we look at the pharmacotherapy of allergic rhinitis, we see that oral antihistamines are very good for nasal itch and not so powerful in other areas. Eye drops are great for the eyes, whether they're the cromolins or antihistamines. Corticosteroids are very, very good for sneezing and rhinorrhea, but also have a decent effect upon nasal obstruction and itch. Unfortunately, decongestants are fantastic at relieving nasal obstruction. Unfortunately, because tachyphylaxis occurs to things like Sinex, oxymetazoline, so that you need increasing doses to achieve the same effect. It takes 5 to 7 days for the nose to become addicted to it. So very, very good at the beginning, if somebody's suffering for the first 2 or 3 days, to open up the nose to allow the other drops to get in. Anticholinergics are great for a runny nose, for the senile rhinorrhea, excellent medication. Anti-leukotriene receptor antagonists are not as powerful or as potent as antihistamines. But the combination of topical nasal steroids and topical antihistamines hits the bill across the board. So another practice audit point: how many patients are on a combination of topical nasal steroids and oral antihistamines for perennial allergic rhinitis or seasonal allergic rhinitis? That would be worthwhile looking at. No talk would be complete without talking about saline nasal irrigation, which can also be purchased over the counter, although it's prescribable. So this is for people who like natural cures because it's just salty water, but also it works. There is a massive improvement in nasal symptoms. Medication usage is reduced by 61%. Mucociliary clearance is improved by 31%. And there's a 30% improvement in quality of life. So that is something to think about with everybody who suffers from allergic rhinitis. And there's a small study from Asia demonstrating that nasal saline irrigation in children with allergic rhinitis also helps to improve asthma control. So thinking about integrating respiratory care, when a patient comes for their asthma review, we should ask them to identify allergic rhinitis. Have you noticed any problems with your nose? Do you have a runny or blocked nose, sneezing or itching? Do you snore at night? Is your sense of smell impaired? Do you have hay fever or a cold that does not go away? And one of the other common names for hay fever is the summer cold. Are your eyes affected? And then, are your symptoms constant or seasonal? Are you taking any treatment? And if so, what they are? And then do a score the nasal symptoms on a visual analog scale. Very easy to do. Score of 0 to 10. How do you think your nasal symptoms are? And the patient puts their finger down. It sums up everything. It sums up everything that the questionnaires cover. If the score is less than 5, then they've got mild disease. If it's 5 to 10, it's moderate to severe. And you can these flow charts can be found in guidelines in practice in I think it was the October issue last year. You can avoid advised avoidance. Start off the topical nasal steroids that become controlled, or they may not be controlled. If they're not controlled, then you can add in a topical nasal steroid and antihistamine. And if you fail to continue to fail to be controlled, consider referring to an ear, nose, throat specialist. So let's just briefly consider the evidence for intranasal steroids in asthma. This meta-analysis was published a few years ago in Allergy. The hypothesis was that reducing inflammation in the upper airways with intranasal corticosteroids may improve asthma outcomes. And actually, it showed that the FEV1 improved, asthma symptom scores improved, and that there was a decrease in rescue medication. So there's little doubt whatsoever that using topical nasal steroids in the nose will improve asthma outcomes with those with concomitant disease. The latest piece of evidence, published very recently, studying a population of people in the UK, people with allergic rhinitis and asthma symptoms using topical nasal steroids and antihistamine to treat multimorbid allergic rhinitis and asthma. The treatment of the asthma was associated with improved visual analog scales across all the study parameters, including improvement in symptoms, asthma symptoms, sleep quality, and daily work or school activities, as well as outdoor activities and social activities. The asthma symptom severity decreased from a mean of nearly 5 or 50 millimeters to 24, and the self-reported frequency of asthma reliever medication was reduced also. So looking at those by category, sleep quality improved across the board. There are two lines there, one line for those with allergic rhinitis and the other for allergic rhinitis with asthma. And you can see the results are the same for both. There's an improvement in sleep quality by improving daily over 2 weeks in their work impairment and in their social activities. And looking very specifically at asthma, we see the reduction from an average of 50 millimeters down to just over 25 millimeters. So it just demonstrates the importance of looking at the airway as a whole. Very important to educate the patient about the nature of the disease, the possible need for long-term treatment, and taking it regularly. They need to be shown how to use it. They need to be aware of the possible side effects. And with the once-a-day topical nasal steroids, fluticasone or mometasone, the side effects are minimal. And also alert them to the possibility of mobile monitoring using the Mask Air app. A few words about immunotherapy. Allergic rhinitis is a frequent precursor of asthma. Most patients with allergic rhinitis have allergic asthma. Most patients with asthma do not have allergic asthma. In allergic asthma, immunotherapy reduces symptoms, reduces medication needs, and improves bronchial hyperresponsiveness. It also reduces exacerbations and has a disease-modifying effect. Let's just look at this publication from the European Academy of Allergy European Academy of Allergy and Clinical Immunology, who might benefit from allergen immunotherapy. Patients with moderate or severe symptoms of rhinitis or rhinoconjunctivitis, as the last speaker referred to, with or without asthma. The symptoms appear on exposure to the relevant aero allergens, which are confirmed on IgE testing. And they are taking all their medications properly and regularly, with a failure to control their symptoms. These are the patients in whom you would consider doing immunotherapy. You also need to check the patient's understanding and commitment, because it's quite a long journey, 3 years for immunotherapy to be truly effective. And if they're not adherent, it's a very expensive way of causing medication not to work. But just looking at the response to Birch's sublingual immunotherapy, we can see across the board there's a reduction in symptom score, medication score, and nasal symptoms. There's the overall score. And that's also accompanied by an increase in various biomarkers within the bloodstream, which demonstrate that the immunotherapy is having an effect. Interestingly, it can also modify asthma progression of allergic rhinitis to asthma. So this is looking at the progression from genus step 1 to step 3, and that's not very marked. But the progression from people with step 3 medication to step 4 is really quite considerable. So that's something we need to be thinking about in terms of grass and birch immunotherapy for our patients with rhinitis and asthma. So, in summary, rhinitis causes a significant health burden. We in primary care have a critical part to play in treating patients and identifying appropriate patients who are suitable for referral to a specialist for further evaluation. The British Society of Allergy Clinical Immunology 2017 suggests a topical nasal steroid and a topical antihistamine taken at the same time when there is a failure to respond to first-line treatment with either an oral antihistamine or topical nasal steroids. Allergic rhinitis and asthma frequently coexist. Always ask people coming for review for upper airway symptoms if they have asthma, and for lower airway symptoms if they have rhinitis. And ultimately continue allergen immunotherapy as a treatment option. I hope you found that interesting. Thank you very much for listening to me this beautiful sunny afternoon.
Thank you so much, Dr. Dermot Ryan. We've now got some questions to put to you. So, can allergic rhinitis cause intermittent cough and occasional wheeze without asthma at the height of the season?
The intermittent cough and the wheeze is asthma. So you might just get a cough because of mucus trickling down the back of your throat, but wheezing is a symptom in the lower airways, and that represents asthma. It may only be very, very mild asthma, but it's asthma nonetheless. The problem is many of these patients will not be monitoring their peak flows, but as I showed in the slide, looking at the response after an acute exposure to the allergen, there will be a drop in peak flow or FEV1 if that was monitored. So up to now, the suggested treatment has been to give these patients intermittent salbutamol, but the latest suggestion from the GINA guidelines would be to give this sort of patient a combination of salbutamol with an inhaled steroid. Or sorry, a combination of formoterol with an inhaled steroid to cope with these symptoms on a PRN as needed basis.
Thank you. So we've got another one for children. This is kind of to do with treatment management. For children on low dose inhaled steroids, but also have perennial allergic rhinitis, what would be your preferred management?
Low dose inhaled steroids by inhaler?
Yes.
If they're taking low dose inhaled steroids by inhaler, I would add a topical nasal steroid, and that would either be mometasone or fluticasone. There is less than 1% systemic absorption of these molecules through the nasal mucosa, and therefore you're adding very, very little to the total steroid burden that this child is having. If you use beclomethasone, flunisolide, triamcinolone, or budesonide, the absorption rate goes up to 30 to 40%, depending on the particular steroid. So you're giving the child a significant steroid load. The preparation for antihistamine plus topical steroid is not licensed for children under the age of 12, so that's actually not an option at the moment. It might also be worthwhile considering nasal irrigation if the child can tolerate it.
Thank you. So there's another question here. I understand that first-line therapy is pharmacology for allergic rhinitis and asthma, but are there any natural remedies that people can try when they have mild hay fever? So you just talked about kind of nasal irrigation. Are there any other self-help therapies that you would suggest?
Vaseline around the nose helps to trap large pollen particles and stops them from getting into the nose. You can also purchase nasal filters, which you put in the nostril, but I believe they're quite uncomfortable to do that. Wearing sunglasses, strangely enough, seems to help reduce the sensitivity to the pollens. Not bringing in your washing inside on a polleny day helps stop spreading the pollen into the house. By the same token, keeping the windows shut during the day stops pollens coming into the house. And I mentioned also about pets. Pollen filters in cars are very, very helpful, but not particularly helpful in the house. That's about it, really.
Is there any evidence that masks have been shown to help with kind of symptoms of allergic rhinitis?
I suppose if they are of a high enough fiber count, so not the sort of surgical masks that we are wearing at the moment, but something better than that, as it were, they probably would have an effect, but I'm not aware of any specific evidence.
Thank you. Are you able to explain further the link between nasal polyps and cystic fibrosis?
Not exactly, except that nasal polyps due to chronic rhinosinusitis or an association with chronic sinusitis tend to occur in people in their 30s, 40s, and 50s, whereas polyps in cystic fibrosis are pathognomic in children with cystic fibrosis. So the chronic rhinosinusitis polyps don't appear in children; they appear much later in life. But I'm afraid the precise pathophysiology behind that, I would not pretend to know. I haven't even ever looked it up, but the link is absolutely clear. If you see a child with nasal polyps, they're cystic fibrosis until proven otherwise.
And is there any evidence to show that having allergic rhinitis or asthma can be worsened during times of stress, especially for allergic symptoms?
Well, I think, as the last speaker pointed out, stress kind of primes the immune system, and there's more inflammatory mediators floating around. So the answer is yes, I think stress does make these things worse. So, for example, it may well be that the symptoms we see, particularly in teenagers in the summertime, is because they've got hay fever and they've got exam stress on top of it, and because they're not sleeping properly and because they can't concentrate properly, the stress builds, and their symptoms are worse with their disease. So yes, there is a link.
There's another question here. Obviously, use of intranasal corticosteroids for allergic rhinitis, inhaled corticosteroids for asthma, and antihistamines. And when would you consider using montelukast?
Well, it's not particularly useful in either asthma with rhinitis and certainly not in allergic rhinitis. So it's really, and it's also a trial and error sort of basis. There aren't any real pointers. I've certainly had one or two absolutely stunning responses to montelukast, but it's very, very rare. 30 to 40% of people have absolutely no response to montelukast at all. The rest tend to be very, very average, but some people do really, really well. Of note is the recent warnings about the psychoactivity of montelukast, particularly on children's brains, causing psychotic reactions. So that's something to take to weigh up and put into the equation.
Thank you very much. That's all your questions for today, Dr. Ryan. Thank you very much for that very informative talk. So now we're going to go over to Dr. Stephen Jenkins, who is a consultant physician in respiratory and allergy at Mid-Essex Hospital, and he will talk to us today on food allergy and young people and adults, with a focus on seasonal allergy. Welcome, Dr. Jenkins.
Good afternoon. Thank you very much for inviting me along. Can I just check before we start that you can hear me okay? I'm hoping I'm hoping that you can all hear me fine. So thank you very much. It sounds like it's been a long afternoon, some great presentations. I'm going to talk to you about food allergy in young people and adults. So I'm not going to be referring to children here. Many thanks for the opportunity to speak to such a wide audience. I noticed that most of you are coming from primary care. So I hope that this talk, which is very much aimed at a primary care audience, will be of help, although I note that there are some other specialties such as ENT and dermatology in the audience. For those of you who find the talk helpful, I'm very happy for you to pick up my slides at the end of the webinar. So very happy for you to get copies of my slides if that would be helpful. Obviously, food allergy is often a very hot topic. I'm sure you have come across some of the cases of very tragic cases of deaths in young people due to food allergy, which you have heard about in the media. So we'll talk a little bit about that today and perhaps put it into context and emphasize that these are relatively rare events. So really first, just to talk about my background, which may help you understand the context of this talk. I'm actually a respiratory physician. I'm a jobbing clinician rather than an academic, but I run a very busy allergy service. And I interact a lot with primary care around referrals for food allergy. But my story perhaps tells you a little bit about the problems we have with allergy services in the UK. So as I say, I'm a secondary care clinician. My background is in respiratory medicine. I developed an interest in allergy and asthma through my research. And when I first developed a consultant post, I had a small immunotherapy service to build an allergy service alongside. And gradually, the demand for this service grew over the years, such that a trickle of referrals became something of a tidal wave over time. We now cover a catchment area within Essex of about 1 million people, and we have developed very long waiting lists, which go up to 12 months at its worst. Within our service, which is in a small hospital, we've developed services including immunotherapy and complex drug allergy testing and challenge and administration of biologics. We link to Addenbrooke's, and our clinic is one of only 2 adult allergy clinics across the whole of Eastern region, the east of UK, which covers all the way from Hertfordshire, Northamptonshire, Bedfordshire and East Anglia. So access to allergy services for many of you is very difficult, and I think that is a huge problem. It's a problem that Allergy UK have been struggling with for decades. For many of you, particularly in areas, perhaps less well-populated areas of the country, the geographic distances for patients to attend an allergy clinic are huge at times. And so that is a real problem in primary care, where you will see large numbers of patients with the atopic conditions that we have discussed today. With food allergy is actually a pretty common one of those. So the charitable sector, such as Allergy UK, often find themselves filling the gap. And patients, rather disastrously, often turn to dubious practitioners in the alternative health sector for dubious testing, which can set them on the wrong road. So the traditional model that we used perhaps prior to COVID was that the GP would refer a patient to our allergy clinic. We would offer the patient a face-to-face appointment. We would do some skin prick testing, maybe follow that up with some RAS testing and achieve a diagnosis. We now try to screen referrals as much as possible and encourage you guys to do testing in primary care where possible. And with COVID, we have not been doing face-to-face appointments for some time. So typically now we might have an electronic referral or an advice and guidance request that would be triaged with advice and maybe a request to do some RAS testing. And after that, perhaps only those with significant results might come through to a telephone clinic. And if there's still uncertainty, we might then bring them to a face-to-face appointment for skin testing if needed. So a slightly smarter model, if you like. So that's the context. These are the key aspects about food allergy I'm going to be talking about today. Hopefully it's going to be useful practical advice for you. Essentially diagnosis and management. Diagnosis is basically about taking a good history, looking at the sequence of events, suspected causes, symptoms and cofactors, and then following that up with appropriate testing, which can either be blood testing in the form of specific IgE or RAS testing and skin testing. And management is actually straightforward. It's about avoiding the food, educating the patient, and appropriate use of an adrenaline autoinjector. Currently, we don't have specific treatments for food allergy. There is some work going on with desensitization, some successful studies in children, but currently that's not a treatment that is routine in adults, nor will be for some time. So to start off with, it's worth thinking about how food allergy presents. Now, you will have many patients come to you in clinic in primary care saying that they think they're allergic to foods, and a large proportion of them won't. So it's important to focus on what the key aspects of the history are. Allergy symptoms, symptoms of immediate hypersensitivity, IgE-mediated reactions. So typically these might be itching or tingling within the mouth, with or without swelling in the oral cavity. Often you will have itching, which can be generalized, maybe in the palms or soles, associated with urticaria or other types of rashes acutely. In some cases, wheezing or bronchospasm, sometimes GI upset with vomiting and diarrhea, and sometimes rhinitis. So these are the features of a type 1 hypersensitivity response. Much less likely to be food allergy if the patient says they've got a funny rash, tummy pain, palpitations, mouth ulcers, sore throat, non-specific symptoms. And I think it's important to push back against food allergy as a diagnosis in that context. And the key thing is timing. So when you're taking an allergy-focused history, you look at the timing. So food allergy reactions occur in seconds to minutes from ingestion of the food to the first symptom. And there are very few exceptions to this. So if it is not immediate, it almost certainly isn't food allergy, and that will help you. There are cofactors that might increase the severity of reactions or lower the threshold at which a certain amount of food may trigger a reaction, and these would include exercise, along with sleep disturbance and other things, and lots of work going on in that area at the moment. We'll talk a little bit more about exercise later. So the patterns or severity can vary. So not all food allergy is severe, and a lot of the work you can do in primary care is about reassuring people with a history of relatively mild food allergy. So with milder reactions, you may see just some itching and tingling in the mouth, or maybe some very mild swelling. And these reactions, often no treatment is required. We'll talk a little bit about pollen food syndrome a little later on, which is a manifestation of this. More moderate reactions might involve a greater degree of swelling, maybe with some urticaria or some GI and nasal symptoms. And these might require treatment with an oral antihistamine. But more severe reactions on the spectrum consistent with anaphylaxis involve ABC, so airway, breathing or circulation. So airway would involve throat swelling or severe tongue swelling. Breathing would involve wheezing or bronchospasm. Circulatory problems typically would involve dizziness, hypotension and collapse, and these are the ones that we treated with adrenaline. And of course, these are the ones that we're really worried about. Those are classical immediate responses. You will see other patterns of presentation. I was going to talk to you a little bit about some of those to help you perhaps appreciate some of the ways that people might come to you in the clinic. So delayed food reactions that are allergic can occur. They are very rare. I don't want to dwell on them. They can sometimes be seen with seafood. There is a rare syndrome of delayed anaphylactic reactions to meat. Eggs, for instance, can cause mainly GI-related symptoms, but again, that's relatively unusual. And if you think about celiac disease, which is thought of as a food allergy, actually it's an autoimmune condition which is induced or triggered by food. So it's not IgE mediated as such, but is considered by some as a food allergy. Then there are non-allergic food-related phenomena. And in these patients, the allergy testing, the specific IgE testing, will be negative. So for instance, with food intolerance associated with IBS-like symptoms, bloating, abdominal pain, diarrhea, this is related to a different mechanism. Testing is unhelpful. And in these patients, really, you just have to give them some simple advice about trying to avoid, for instance, weeds, or trying a FODMAP diet and making sure they don't have another GI pathology. But I don't generally do any food allergy testing in those sorts of patients. A small minority of patients will react to food additives like sulfites or benzoates. Typically, you might see a patient who drinks wine, red wine especially, might get a rash or a runny nose. So that's a pattern one can see. Again, there's no specific testing available for that. There is a particular type of food poisoning called scombroid, common in cooked fish that's left laying around for a while and leads to a toxin-mediated pseudo-allergic reaction, which mimics a food allergy. But in those patients, testing would be negative and they can continue to eat the food. And it's important to mention these two conditions, so chronic spontaneous urticaria and idiopathic angioedema, both of which are autoimmune conditions, internally driven, associated with recurrent hives or mouth or tongue swellings, which are often perceived by patients and doctors to be due to food allergy, and are generally not. So what are the key food allergens? And this will again help you in the history, and you know most of these. So these are the obvious things in adults as well as in children. So it's peanuts classically, also other forms of tree nuts. Seeds are absolutely crucial and very potent allergens. Seafood, legumes such as soya and pulses, and then the common daily foods such as egg, milk and wheat, and fruits, which we'll describe later. In patients with an unclear history, we sometimes look for hidden food allergens, and ones to be aware of include mustard and celery, which can get into seasoned foods, lupin flour, which is related to peanut flour and is used sometimes in pizza, gram flour, which is from chickpeas, buckwheat and soya, which can be hidden ingredients. Those type of hidden ingredients are rare, and in most patients, actually, the history of food allergy is pretty obvious. For rarer foods, you will sometimes find, you can find rare case reports of less commonly described foods. That's the sort of thing we do in the rarer cases in the allergy clinic. But if you see a patient coming to you with a history of reacting to things that are not food allergens, like salt, sugar, coffee, oil, sweets, etc., it helps you to very clearly discount food allergy as a cause now, because they're not proteins and they're not recognized food allergens as such. Now, it's just worth mentioning about what we call cross-reactivity. So if you react to one food, you may well react to others within a family. So typically, this will relate to the well-known, this is about plant biology. So the classic one I will describe in more detail further on is pollen food syndrome, where you'll react to a pollen, such as tree pollen, and cross-react with fruits and nuts. But there are many other plant families to be aware of. I don't expect you guys to know these in full, but just to give you an idea that this helps us understand the pattern of presentation in patients. So one here called LTP, or lipid transfer protein, is a marker for more severe reactions to fruits and vegetables, and those can be very severe. There is a phenomenon called latex fruit syndrome, where people react to latex and various tropical fruits. And if you think of latex as a rubber which grows on a tree that is grown in tropical areas. We also have certain syndromes with cross-reactivity between weed pollens and, for instance, spices, as you can see here. And the other thing to mention is that the storage proteins are a marker for more severe allergy that you see in nuts, which often cross-react with legumes and seeds. So to pick up the seasonal theme of today's webinar, this condition is one I want you to all take home and maybe read about a bit more, because you will all see patients with this condition in primary care, and it's not necessarily well known about. It's called pollen food syndrome, also known as oral allergy syndrome. And in these patients, typically they will have pollen allergy, usually trees, with birch pollen as what you might describe as the triggering allergen. And because of a cross-reactive allergenic protein, which is shared with other plant foods, people will react to typically fruits, certain raw vegetables, and peanuts and tree nuts. The fruits typically involve apples, cherries, pears, sort of Mediterranean style fruits. Typically these patients will tolerate citrus and banana relatively well. The reactions are very mild, generally, itching or tingling in the mouth. And a very interesting thing about this is it's a heat sensitive allergen. So they will reactions will occur with raw foods. But for instance, if you cook the fruit, if you roast the nut, patients won't react. They'll have no problems with jam or processed juices. Interestingly, they can develop itching and rash on the hands when they're peeling potatoes. And these patients just need to be reassured. They don't need an adrenaline pen. I generally don't do testing in clinic when the history is good. A couple of exceptions to that is that, interestingly, if you put all these fruits together in a smoothie and mix it all up, you don't denature the allergen, but you increase the quantity. So some patients occasionally can react more severely to a smoothie. And the other very interesting seasonal phenomenon you can see in these patients is I've seen a couple of patients where they'll drink soya milk during the tree pollen season, will actually have a more severe reaction, whereas outside of the pollen season, they would be less likely to react in a severe way. So this is an important syndrome to recognize. Another variant on the clinical presentation worth being aware of is this fascinating phenomenon of food-dependent exercise-induced anaphylaxis. And in this situation, and typically we see it with wheat, the patient will be able to tolerate the food without problems unless they exercise. But if they eat, for instance, wheat and then exercise, they will develop a delayed reaction, typically 1 to 4 hours later, which is often severe in the form of anaphylaxis. The mechanism is unclear, but it's likely that exercise alters the way that the food is digested and presented to the immune system. And we have a specific component blood test called omega-5 gliadin, which is useful for wheat-induced exercise-induced anaphylaxis. And these patients should carry adrenaline, and they will be advised to avoid the food alongside exercise. So before we talk about testing, which is a crucial aspect here, I just want to touch on these three contexts of sensitization, allergy, and tolerance, which will allow you to understand the results of these specific IgE tests better. So sensitization is the process's development of a specific IgE response to an allergen. And that would be manifest by a positive allergy test, either a skin prick test or a specific IgE or RAS test. So that's showing that you're producing these specific IgE antibodies to that particular, whether it's a food or a pollen or whatever. But it doesn't mean you're allergic. To be allergic, you also have to be sensitized plus respond in real life. So allergy means sensitization plus clinical real life reactivity in a real world setting. And it needs to be reproducible from one day to the next. So you need to react to peanuts on a Monday, a Wednesday, and a Friday, rather than just on the Monday. The opposite to that would be tolerance, where you are sensitized without clinical allergy. So in that situation, you might have a positive skin test to peanuts, but be able to eat them. And that might be either primary or secondary. You could have grown out of an allergy, as often happens to children, or you may have already had it from the beginning. And these are the three important contexts to be aware of. So how do we test for allergy? So the classical testing method we used was skin prick testing, where we use extracts of food antigens, drops on the skin, pricking of the skin with a small lancet, and after 15 minutes you look for the presence of an itchy bump or a wheal. We measure the size of it, we compare it to a positive and negative control. And this is a very reliable form of testing. Unfortunately, it can't be done in most cases in primary care, which is a limiting factor. If we want to extend skin prick testing, we can do something called prick-to-prick testing, where we actually use the fresh food rather than extract. And in this situation, you literally stick the needle or the lancet in the food and then gently stick it into the skin and use fresh food, and you read it off in the same way. And that can be funny at times as we try to prepare foods to do this. Not very pleasant if you're doing seafood at the first clinic visit of the day, stinks out your clinic room. But it's very useful in certain food allergens. So particularly sesame, crustacea and fruits, it will increase the sensitivity of testing over and above conventional skin prick test reagents or RAS testing. So a better term rather than RAS is specific IgE. And in this, we are measuring the body's IgE response to an allergen. You can quantify the response, which is very useful. A word for primary care, the total IgE is a very unhelpful test. So total IgE is non-specific. It is influenced by other factors such as smoking or infection. So a raised total IgE is not indicative of allergy at all. But specific IgE will correlate well with allergy, and a positive specific IgE means that you're sensitized at the very least. In addition to specific IgE testing, we can also do component testing. So in this, we actually break down into more individual protein allergens. And this forms an allergy profile, which we find useful in the clinic to help us guide diagnosis and in particular to assess severity. So for instance, for peanut, you can do a peanut skin prick test or a peanut RAS. But within that profile, there are a number of peanut allergens which are numbered. As you can see here, they're numbered from ARA H1 up to ARA H8 and beyond. If you look at ARA H8, that maps across to the pollen food syndrome. So if it's only ARA H8 positive, these patients have mild peanut allergy, which is pollen related. In contrast, ARA H2 positivity is a strong predictor for a more severe reaction. So we use that as a tool generally to guide risk assessment and often prescription of adrenaline pens. And there are similar tools available for hazelnut, which allow us to predict severity. And there are also tools to allow us to differentiate lipid transfer protein allergy, which is more severe form of fruit allergy, from pollen food syndrome. And there's no doubt that component testing is going to expand over the years. And this is a tool that I think can be useful in primary care as long as you're given guidance on how to interpret it. So the ultimate allergy test is a challenge test where a patient ingests a food. We try to avoid doing too many of these. We don't do that many in adults compared to children. But these tests, in my practice, are designed to be negative. So it may be used to rule out allergies. You may have a patient who's actually got idiopathic angioedema, who presents with what was thought to be prawn allergy. We do a skin test, it's negative. We do a RAS, it's negative. So we'll then proceed to challenge to confirm that the patient is not allergic. It can be done to confirm that the patient's developed tolerance, to see whether they've outgrown a childhood allergy. And it can also be done in some patients to confirm safe cross-reactivity. So for instance, if they've got peanut allergy, you might sometimes look to see whether they're able to ingest other nuts, such as walnuts, particularly in a patient who might be vegetarian. Challenges can be done at home or at hospital, depending on assessment of risk. And essentially, it's a regime that involves a gradual introduction to a food, typically with a rubbing of the food on the outside of the lip, followed by a 15-minute gap, followed by the inside of the lip, followed by a series of stages from there. So you can see this sort of progression of testing that you might do there to exclude a food allergy involving challenge at the end. Again, that's not a test that we'd be expecting you to do in primary care. So I think this is really crucial for primary care audience. How can you use RAS? I'm sure many of you do use RAS testing, and many of you will be asking for advice on the results from maybe your local immunology lab or from your allergy service. The most important thing about RAS is it needs to be preceded by a sensible history, which can be very useful. So this can be a very useful test to reassure a patient when you don't think they've got a food allergy. So, if they've got very non-specific symptoms, if they're convinced they've got food allergy, one simple thing is to do a food mix RAST. It covers the 6 main common foods. And if that's negative, that's often very useful. A negative test generally rules out allergy. There are exceptions, as we discussed earlier, but it's a useful way to start the referral process to an allergy clinic, whether that's through advice and guidance or through a referral pathway. And as you can imagine, for patients who are travelling 50, 100 yards for a clinic appointment, if you've started the process off with RAST, I think that makes an awful lot of sense. So, having discussed testing, I'm going to talk to you a little bit about management of food allergy, and then we'll talk a little bit about food allergy anaphylaxis at the end. So once we've diagnosed a patient with a food allergy, we're going to advise them to avoid the food. But the patients need a strategy or a plan. So it's got to be a nuanced advice. And that advice and how much it impacts on the patient's life will depend upon the underlying risk. So for instance, we're going to take a different approach to a patient with mild pollen food syndrome than we would to somebody with a history of severe nut allergy. So they're obviously going to be avoiding the index food, and they may or may not be avoiding cross-reactive foods. So for instance, with severe nut allergy, in general, we are going to, on a precautionary basis, advise the patient to avoid all nuts, because that's the sensible thing to do. Whereas with a pollen food syndrome, if you've reacted mildly to apples, you need to be aware that you might react to other fruits, but you don't need to avoid them. Testing can help the avoidance strategy. One factor that will come into play is events. So sometimes patients will inadvertently ingest a food and find that they can tolerate it, and that information can be useful to guide their strategy going forward. Clearly, for most patients, they need advice on where they are at most risk. So it's when their guard is down, when they don't know the provenance of the food, if they haven't cooked it themselves or in their own kitchen, so restaurants, buffet meals, dinner parties, catered foods, foreign travel. And I'm sure you've heard many stories in the media about how that can be so challenging for patients. And for patients where the avoidance gives them dietary issues, especially if they're vegetarian, then support from a dietitian is going to be very useful. Although for many of us, access to allergy-based dietitian services is limited. What about trace labelling? Well, this is a nightmare for patients. This is a topic which is, I'm sure, very close to the heart of our sponsors, Allergy UK. So these labels of may contain or made in a factory with, etc., etc. And I think you've got two issues here. One is that sometimes this is just done by a food company to cover themselves, and actually the risk of contamination is low. Whereas in other foods, such as snack bars, the risk of contamination is really high. And you can imagine in a factory making snack bars where you've got nuts and seeds flying around everywhere, contamination is much more likely. In general, my personal view is that really we only need to caution patients about trace labelling when they have a severe allergy, as an example for those patients who carry an adrenaline auto-injector. We don't know enough about this, but we're now studying it in more detail. We are lots of studies going on looking at the threshold for an allergic reaction trigger in a patient. So even in patients with severe allergy, you can define the threshold. In other words, what would be the quantity in micrograms of, for instance, peanuts that would set somebody off. And the reassuring news is that even for most severe patients, may contain foods in most cases don't exceed those thresholds, but there will be exceptions to that. And until we've got greater clarity from the food industry, I'm afraid we are going to continue with advising people to avoid those foods if they have a severe allergy. So for patients with severe allergy, we would expect you to supply the patient with an adrenaline pen, an adrenaline auto-injector. So who gets them? And this is a thorny topic. Hopefully I can help guide you through this. For patients with a history of a potentially life-threatening reaction, so any of the anaphylaxis bits that we talked about earlier, people who react to trace quantities, people with coexistent asthma, and or people with progressively severe reactions, then adrenaline auto-injector is warranted. There are other factors which will nuance the decision, and these would include the food allergen itself, where how easy or not it is to avoid it. So for instance, not so much harder to avoid in general than, for instance, certain seafood allergens. If the patient is very geographically isolated, that might increase the likelihood. Parental concern or the patient concern is a factor. It shouldn't be a deciding factor. So we shouldn't just give them to people just because they're worried. Teenagers are an issue, with especially males, with their tendency for risk-taking behaviour, so that might colour the decision. It's important to say that this is a subjective decision with no clear consensus, with a fairly patchy evidence base. So if you use the sensible risk management principles, and I think as a GP or primary care nurse, if you're in doubt about whether to give an adrenaline pen, you probably should give it. Most importantly, you shouldn't wait for an allergy clinic appointment. I've had a number of referrals recently where patients have said, the GP have said they're not allowed to give an adrenaline pen, which we all know isn't true. The other converse mistake is we shouldn't in general be giving patients adrenaline pens to patients with classical chronic urticaria or recurrent angioedema where it's non-severe. So prescription adrenaline pens can be done by secondary care. It should be done by ED for people presenting with anaphylaxis, or by GPs or primary care nurses. The recommendation from MHRA is that actually all patients should have 2 pens. In our allergy society, the BRIAS ACI, we actually recommend that most patients can get away with 1 adrenaline autoinjector unless we are particularly concerned about geographic isolation or especially severe or biphasic reactions. If you prescribe the pen, these factors are absolutely crucial. There is no point having a prescription if the patient doesn't keep it on their person at all times. They need to have some training, ideally from a healthcare professional, and to reinforce that themselves by looking at training videos specific for the product that they've been supplied. We should be encouraging them to download the mobile phone apps, which can really support that training. Patients should have reminders to renew the product when it goes out of date, and patients should have a written anaphylaxis management plan to guide how and when they should use the pen. Without those supporting tools, the pen is not going to be helpful for reasons we'll find out in a second. So unfortunately, food allergy does kill. Thankfully, it is a rare event. It's rare but tragic, and often avoidable, and typically it tragically shortens the life of young people. It's probably, however, not as common as it's perceived, and it's important we put the risk into context when we talk to patients. So for instance, anaphylaxis deaths over a 6-year period in this study were approximately 20 per year. And I'm going to present you some data very briefly from some studies of anaphylaxis deaths from a guy called Richard Pumphrey, who looked at some of the tragic stories behind these deaths. As you can see here, peanuts are by far the commonest cause of food allergy. And you can see in this period from 1990 to 2006, approximately 7 or 8 per year in the UK. And of these patients, only a minority of them had previous reactions. Most hadn't. But of those patients that had had an adrenaline autoinjector before, and some of them it was unused, someone had given it to someone else and not replaced it. One patient had not taken their kit to a restaurant. In another patient, the kit was out of date. This is in fatal cases, by the way. One patient was thought to have collapsed too quickly before they could use it. One patient was found dead holding an unused kit. The assumption was that they couldn't assemble the adrenaline pen. Of those that used adrenaline, one patient was waiting in a pharmacy for it to be dispensed. One patient was reported to be advised to spray it into the mouth rather than inject it. Some patients used it correctly without benefit, so it's not always successful. That's the other thing. From a more recent cohort, again, of patients that had been supplied with an adrenaline pen. These are some of the stories you can see here. Used correctly in 9 patients. 2 patients, it was past the expiry date. Several patients were unable to get an effective IM injection because of adipose tissue. and in other patients, the pen was used too late. And look at this story at the bottom, 16-year-old girl who took the risk of eating a chocolate bar because she thought the pen would save her life. So that's a failure of education, as you can see. And finally, just to touch on the story of asthma. So most of these food allergy deaths had patients with poorly controlled asthma, including overuse of salbutamol in the days leading up to death. So poorly controlled asthma seems to be a risk factor and a mode of death in these patients. So we should be encouraging all of these patients with severe food allergy to control their asthma really strongly. And just very briefly on the setting, many of these deaths occurred at home, more commonly than out in restaurants, but actually most of this was with catered, packaged, rather than domestically prepared foods. Okay, so in the interest of time, I'm going to stop there just to summarize the key messages from this talk. Food allergy is a common phenomenon that you will see in primary care. You will also see a number of other patients presenting with symptoms that they think are due to food allergy. So what we'd like you to do is, in the time that you have available, to take a simple allergy-focused history. And remember that classical food allergy has a very clear history in most cases. Try and listen to the patient because the diagnosis will usually be clear, but you don't always have to agree with what they say. In primary care, you can use RAS testing, sensibly done, guided by history, as a guide to how and when to refer. And that you can use the referral pathways that we talked around advice and guidance or electronic referral to take that forward for selected patients. Food allergy deaths are rare but tragic, and in many cases preventable. And we should be supplying adrenaline pens for high-risk cases with supporting advice. So I'll stop there. I hope that's been helpful. As I say, please take the slides if those will be useful, and I'm happy to answer questions.
Thank you, Dr. Steve Jenkins. So now we're going to go to all our questions that we've got lined up for you after your very interesting talk. So there's a question here to say, obviously in children you tend to repeat skin prick testing at various stages to see if they've outgrown their allergies. Would you request doing repeat skin prick testing for young people and adults?
Certainly not in the same sort of level. I typically say to people, if for instance, a childhood allergy is persisted into the late teens or early adult life, the advice to the patient is that they're likely to be stuck with it for a period of time. So I usually say not for another 5 years minimum.
Thank you. Obviously, a lot of young people and adults can display anxiety and stress around food, especially when they feel they have an allergy. And sometimes this is even without supporting evidence. How do you go about trying to convince patients that they can eat the foods?
Well, it's a nightmare, and I think it's made worse by the modern world that we live in, and anxiety levels are heightening generally anyway. There are some of these patients, obviously one of the tools is to make an accurate diagnosis. So this is where allergy clinics have got to do their hard work. Some of these patients won't actually be food allergic at all, and we'll say that to them. Some of them may have a mild food allergy, but actually the severity of it they can be reassured about. Some of them do have a severe food allergy, but it's just got to be put into context. So it's about making an accurate diagnosis, plus trying to provide support where we can. This is where specialist nurses play a huge role. And where anxiety is a very strong amplifying factor, you've got to try and access mental health support where you can. I mean, I've had many cases where I've successfully taken people from being hugely anxious about food to then developing a more normal approach to food and a much better quality of life. There's some other people where I just haven't been successful in that. I think there are elements of food phobia and almost, borderline with sort of anorexic tendencies in some patients. So it's all we can do really is try to make an accurate diagnosis and then take things on from there.
Thank you. There's another question here, how to assess patients. So reactions or anaphylaxis, especially if there's no history of anaphylaxis previously.
Sorry, I missed the first part of the question.
How would you kind of assess patients who are more likely to have severe allergic reactions or anaphylaxis? There's no history of anaphylaxis previously.
I guess you can't. I mean, I think all you can do is take the reactions that they've had on their merits. And if they haven't had a severe reaction before, you shouldn't assume that they will have them again. All you can really do is take the index reaction on its merits. You then do the testing, and then you risk assess and advise from there. So, for instance, if you had a patient who reacted to peanuts with, you know, mild to moderate lip and tongue swelling, but nothing more severe than that, the only thing you can add to that is the use of this component test. So if you've got a very strong positive RH2 component test, I would in that situation offer an adrenaline pen. But aside from that type of component test, let's say if you had a different food, like let's use as an example, prawn or fish, if you had a mild to moderate reaction, I think what you say to the patient is you're allergic, you should avoid, you don't need to carry adrenaline pen. So we don't generally have clear ways to predict what will happen in the future. It is an unpredictable feast. But I think it's important to try to reassure where possible. And again, I'm sure you've all come across people who are hugely anxious in this situation. It's about trying to manage that as best one can. And again, you know, knowledge is power. The more you know about the patient's test results, the more you can inform them in a way that's informed and therefore authoritative.
Thank you. And another question: can medications such as oral steroids or topical steroids influence the results of total IgE or specific IgE or skin prick testing?
Definitely not for specific IgE. So you can do RAST specific IgE testing in primary care if they're on steroids or if they're on antihistamines, and it won't affect that. As regards skin testing, we generally work around that. They don't actually have a massive impact on that either. But from a point of view of specific IgE, there's no effect.
Thank you. And there's another one here to do with kind of total IgE. Is total IgE influenced by other factors such as smoking, etc.? If the specific IgE is elevated due to an allergy, will the total IgE always be raised?
Yeah, it's a good question. I think definitely smoking, infection, and a whole host of other factors, including eczema, by the way, will push up total IgE. So what you don't need to think in a patient with an elevated total IgE is they must be allergic to something. We don't need to think that way. And the mechanisms for that are many and complex. And for instance, patients with eczema will often have IgE of over 5,000, where the upper limit of normal is just above 100. If you do have positive specifics, it will push your total IgE up. You can interestingly look at the specific titer in relation to the total IgE. It's not something we do routinely, but if you've got a specific IgE of 0.36, which is just above the limit of normal, and total is 5,000, it would suggest that it's less clinically relevant than if the total IgE is lower. So you've got to look at the two of them in context. But you know, I look at the total IgE, but I think if it's higher, you've got to take it with a pinch of salt.
That leads on to the next question. Would you do a food IgE, specific IgE in patients with eczema?
Yeah, if I'm honest with you, I try not to. My feeling on eczema in adults is that the link to food asthma, to food allergy is relatively limited. Obviously, we all know about the links in childhood where, you know, there is a strong link between food allergy and eczema, although it's a two-way link, isn't it? I mean, it may well be that eczema predisposes to food allergy rather than necessarily food allergy makes eczema worse. But I think there's a merit in childhood to doing specific IgE testing. In eczema routinely in adults, I'm not convinced there's a benefit unless the patient has a strong sense themselves that food allergy is making them worse. And in that situation, my experience is that the tests are difficult to interpret because of this very strongly elevated IgE. But sometimes if you've got certain foods singing out, you can advise the patient to try an avoidance diet. In my personal experience, and again, I'm not an eczema expert or a dermatologist, my feeling is in adults, eczema is most importantly triggered by stress and staphylococcal superinfection rather than food allergy.
Thank you. I've got another one here about kind of a low histamine diet. Questioning if an antihistamine is not helping, is there any point of low histamine diets?
I'm not a great fan of them, no. I guess it depends what you're trying to treat. I imagine that you're talking there about chronic urticaria, and I'm not a great fan of that for chronic urticaria, no. Although if a patient's trying it and they find it helpful, then, you know, it's important to support them in that. But no, I don't think there's much science behind that.
And in oral food allergy, what are the common foods that cause problems in the UK?
Yeah, so in terms of the pollen food syndrome, I think they're talking about there, the oral allergy syndrome. So the one to go for if you're asking about it is apples. Of the fruits, you're looking at apples, pears, cherries, nectarines, peach, grape, certain berries. In the raw vegetables, you will see it with carrot, celery and parsnip. And for nuts, it would be generally tree nuts, so classically hazelnut, walnut, almond, sometimes peanut. But if you look at the, I put a plug here for Allergy UK's excellent patient information leaflets. They've got an excellent patient information leaflet on oral allergy syndrome. There's also quite a good Wikipedia entry, which gives you nice lists of the foods involved.
Thank you. Well, thank you very much for your very informative talk and your grilling there with all the questions and answers. You did very well.
Pleasure.
Thank you. So I'd just like to say thank you to all the wonderful speakers today for your excellent and informative presentations. They have been absolutely fantastic. We've had a lot of feedback to say thank you to all the speakers, that they found the presentations really, really helpful and the information discussed. I'm sure we're now quite happy we're discussing all the allergic conditions, the differential diagnoses, signs and symptoms of allergic disease, medical pharmacotherapy and other treatments would be useful, and when not to use diagnostic testing in the management of these conditions. Looking out for other allergic conditions that may also coexist and be symptomatic, and make sure these are treated effectively. And I'd just like to say thank you to you all for kind of watching and staying for this webinar. So today we'll close our webinar, Stepping into Spring, a focus on seasonal allergies. I hope you found all the information useful. Thank you.